Good evening, guys. Am I audible, visible? Is everything is fine? ऐसे तो पूछना नहीं चाहिए. Everything is fine, but still, at least audio video is fine. Yes, thank you, thank you. Okay, okay. Let me briefly tell you about the session first. Uh, I want to keep the things very straight and to the point. We will be covering all the specialities, means cardio, pulmo, endo, gastro, rheumat, but what I feel personally is very important for you at this particular point of the exam. And what in that also, for example, let's say hypertension. In hypertension, also, what is very important, likely to be asked, I will be covering that part. So I may not be able to see your comment box very regularly because I don't want to unnecessarily engage in these things. So I will just focus more on the content part. You can write down whatever doubt that is there in the chat box. In between, I will see that and will try to cover those things also. Right? Okay. And one more thing we will discuss in between that for these last 30 days almost now from this point, 30 days are left. So how we should really plan for these 30 days, right? So starting with the first point, that is hypertension. From hypertension, there is one question that they love to ask is key, when to start medication. Now, if the blood pressure is 120 to 129 and the diastolic is less than 80, that is elevated blood pressure. And in the elevated blood pressure, we'll just do the lifestyle modification. In the lifestyle modification, if the patient is smoker, quit smoking, quit alcohol, weight reduction, and DASH diet. DASH diet stands for decrease in the sodium in the diet and increase in the potassium and calcium in the diet. Among them, the maximum benefit is going to come from weight reduction. But the main question that is going to come is that in stage 1 or stage 2, when to start medication. If it is a stage 1 hypertension, the systolic is 130 to 139, then you have to search for target organ damage, ACVD score more than 10%, age is more than 65, or the diabetes or CKD is there. If any one is there, ACVD more than 10, age is more than 65, diabetes, CKD, if anything is there, start medication plus lifestyle modification. If none of them is there, just go for lifestyle modification for at least 3 months and then reassess. If there is a stage 2 hypertension, then you should go for medication. So this is the change that is there, the recent change that has came. So stage 1 may whether to go for treatment or not. This is one question that I'm betting on, that whether to go for treatment or not. Target organ damage, ASCVD score more than 10, age more than 65, diabetes, CKD, if it is there, we'll go for medication. Now, what are the medications to be given? If there is hypertension with diabetes, the drug of choice is going to be ACE inhibitor. If not given in the choice, we'll go for ARB. Hypertension with CKD, again ACE inhibitor. If someone has taken cocaine and hypertension is happening because of sympathetic overactivity, we are going to give the sympathetic blockers such as prazosin, clonidine. Hypertension in old age, calcium channel blocker. After myocardial infarction, if there is hypertension is there, the first drug that we prefer is beta blocker. But if the beta blocker is not able to control the blood pressure, then we'll go for ACE inhibitors. What is the target blood pressure when we starting the treatment? If there is only hypertension, the target blood pressure is to bring the blood pressure below 140/90. If the diabetes is also there, then we'll try to bring the blood pressure below 130/80. Here itself, let's talk about the diabetes managed target also. When it comes to the target goal for the treatment of diabetes, we want to bring the HbA1c below 7 and the fasting sugar below 130. So these two targets should be kept clear in the mind when we give the treatment for hypertension and for diabetes. The one more thing is, if the blood pressure is more than 180/120, then you will see the target organ damage is there or not there. If the target organ damage is there, it's called as hypertensive emergency. And In hypertensive emergency, we need to give IV medication. One question is, for example, if they say the blood pressure is very high and because of that the patient has developed seizure, this is referred as hypertensive encephalopathy. What they will ask is, what is the treatment of hypertensive encephalopathy? The treatment is going to be the IV medication. We'll give the IV drugs to decrease the blood pressure, such as labetalol. The second topic we are discussing is heart failure. Whenever a person is having heart failure, while walking, the patient is going to have breathlessness. So they ask that what is the classification for dyspnea, the NYHA classification. If there is no dyspnea, that is class 1. If the patient says, sir, when I go to till second floor, 2 flights of stair, and the patient is developing dyspnea, it is class 2. If the patient is developing dyspnea, even going on the first floor, it is class 3. And dyspnea at rest, it is going to be the class 4. When it comes to heart failure, the marker of heart failure, it is BNP or NT-proBNP. BNP or NT-proBNP will be more. Here itself, let's understand some more markers. When it comes to the myocardial infarction, the marker of myocardial infarction, the earliest to increase, it is IMA, ischemia modified albumin, if not given in the choice, heart fatty acid binding protein. If they say what is the best marker, it is troponin I. If they say what is the future predictor of myocardial infarction, the future predictor is going to be HSCRP, highly sensitive C-reactive protein. When it comes to the management of heart failure, the drugs that we are going to give is ABCD. The CD drugs are going to decrease the symptoms. In the CD drugs, we have the C drug that increases the contractility, that digoxin, and D stands for diuretics and dilators. So first, we always control symptom. If a question comes that there is a patient, he is a known case of hypertension, because hypertension can lead to heart failure. So if they say there is a patient of hypertension, he is coming to you, and while walking, he is developing breathlessness, means he may have developed heart failure. Then they ask that what is the treatment you will give. If the patient is right now symptomatic, you will give furosemide and nitrates. Once the patient becomes stable, we are going to give the AB drugs that is going to increase the survival, such as ACE inhibitors, ARB, aldosterone, ERNI, beta blocker. The question that may come in the exam is, among these drugs, which has the maximum survival benefit? It is the beta blocker. And if they ask that which drug has both the benefit, which drug can decrease the symptom as well as can increase the survival both, then the answer is going to be the SGLT2 blocker. The SGLT2 blocker is going to decrease the symptom as well as it is going to increase the survival. How the SGLT2 blocker works, when in the diabetes patient, when the blood comes to the kidney, the glucose gets filtered. Normally, the glucose gets absorbed with the help of SGLT2. If you block the SGLT2, the glucose will not get absorbed and the glucose will remain in the nephron, and ultimately glucose is lost. Along with the glucose, the water is also lost, so the blood volume is going to decrease, and less blood volume is good for heart failure. So if a person is having diabetes with heart failure, we can go for SGLT2 blockers. The side effect is because the glucose is coming in the urine, so there is going to be UTI, there is going to be weight loss because of the water loss. One more thing here is this particular drug ERNI. ERNI is a combination of two drugs, ARB and NI. ARB is the valsartan and NI is the neprilysin inhibitor. If you give neprilysin inhibitor, the BNP is going to work for a long time, but they ask one question that ERNI is not used for which type of heart failure? It is not used for heart failure with preserved ejection fraction. It is only to be used for heart failure with reduced ejection fraction. This is the management of heart failure. If by any chance they ask that if a person is presenting with acute decompensated heart failure, the drug of choice is going to be the diuretics. We are going to give IV furosemide. Then there is a device that is used in heart failure. That is a recent advance in the heart failure. We can go for a surgery also. That is one of the last thing that we do. Left ventricle assist device, LVAD. It is kind of a pump that we can use for the heart failure patient, LVAD. Now, the next thing we are discussing is the coronary artery disease. When it comes to coronary artery disease, there is a blockage in the coronary artery. If there is a blockage in the coronary artery, there will be either ischemia in the myocardium or there is going to be infarction. How we will differentiate whether it is ischemia or infarction? Whenever there is going to be ischemia or infarction, there is going to be chest pain. So chest pain is going to occur in both of the conditions. The main difference is going to be troponin, whether the troponin is increased or not increased. In the ischemia, it is not going to increase, whereas in the infarction, it is going to increase. The ischemia is when the ischemia happens, we need to see that the ischemia has happened on exertion or at rest. If the ischemia is happening only on exertion, it is stable angina. If the ischemia is happening at the rest, it is unstable angina. When it comes to infarction, if a person is presenting with the chest pain, radiating, the pain is radiating towards the left shoulder and the troponin is more, it's infarction. Then in the ECG, we'll see the ST elevation is there or not there. And based on that, we have two types of the myocardial infarction. If the ST elevation is there, it is ST elevated myocardial infarction. If there is no ST elevation, it is non-ST elevated myocardial infarction. Among these conditions, if you see that these particular three things, in these three things, the patient is having the chest pain at rest. So these three disease comes under the category of acute coronary syndrome, ACS. So they might ask that all of the following comes under the family of acute coronary syndrome, except the answer is going to be stable angina. The stable angina does not come under acute coronary syndrome. Now, the next they ask is how to localize the lesion via ECG. Now, if you look at the ECG leads, how we put the ECG leads is V1, V2, V3, V4, V5, V6. So V1 to V4 are basically located in the anterior part of the chest. V5, V6 in the lateral part. And so we can say that if there is a problem is visible in the V1 to V4, it is indicating that there is an anterior wall problem. V5, V6, first AVL, they are recording the lateral surface of the heart, this area. So if the ST elevation is there in these four leads, then it is a lateral wall myocardial infarction. The second, third AVF is located on the inferior surface. So if there is a problem in second, third AVF, it is the inferior wall MI. So anterior wall, lateral wall, inferior wall. If there is a problem is happening in the anterior wall, V1 to V4 is showing the ST elevation, then most likely the blockage is in the LAD. First AVL V5, V6 is the lateral, and who supplies the lateral area is the LCX. So if first AVL V5, V6 is having ST elevation, means there is going to be LCX blockage. The question which has came in the last exam was this one. They have given a ECG where V1 to V6 was showing ST elevation, along with that first and AVL also, means anterior lead or lateral lead. दोनों में ST elevation था. Anterior and lateral both are not getting the blood, both are, the area is having the infarction. It is the extensive myocardial infarction, and the blockage is in the LMC. Now I will tell you one more question here, one important question here. When it comes to myocardial infarction, normally in the myocardial infarction, the patient develops chest pain and tachycardia. But there is only one myocardial infarction that is having bradycardia. There is only one myocardial infarction that has bradycardia, plus there is nausea, vomiting. So sometimes myocardial infarction can present as nausea, vomiting, and bradycardia. Then the diagnosis is going to be inferior wall myocardial infarction. The only MI which present as bradycardia, nausea, vomiting, inferior wall MI. And inferior wall MI means the blockage is in the RCA, and the leads which will show the ST elevation is going to be second, third area. Now here is the summary of the coronary artery disease. In the coronary artery disease, whenever there is a blockage, what are the ECG changes that we might have? In the coronary artery disease, the changes that we might have is ST elevation, or maybe ST depression, tall T wave, inverted T wave, or biphasic T wave, or large Q. Out of these, any six change, it's not that all the six changes will be there. इनमें से कोई एक या दो चेंज होगा ECG के अंदर. Either ST elevation, depression, tall T, inverted T, biphasic T, large Q, any one of them is there. Then you have to see where it is there. Is it in V1 to V4? Is it in second, third AVF? Is it in first AVL, V5, V6? If it is in second, third AVF, please correct this. If it is in second, third AVF, then it is going towards inferior wall MI. V1 to V4 is anterior wall. First AVL, V5, V6 lateral. If they mention this particular lead that we have placed a special lead V4R, the V4R is put on the right side. It indicates that there is a right ventricle involvement. Then if they say V7, V8, V9, if this word is written V7, V8, V9, we put on the back side, पीछे की तरफ लगाते हैं. So V7, 8, 9 is showing ST elevation, means it is posterior wall myocardial infarction. When it comes to the cardiac markers, the early and the earliest to increase is going to be IMA. If not, then heart fatty acid binding protein. The best is going to be troponin I. The future predictor is going to be HSCRP. Can you tell me that which LDH is going to increase in myocardial infarction? Which LDH is going to increase in myocardial infarction? It is the LDH1 is going to be more than LDH2. Normally, to 2 is more, but in myocardial infarction, 1 will become more, and this is called as flipping of LDH. Can you tell me that in hemolytic anemia, which LDH is going to increase in the blood? In the hemolytic anemia, which LDH is going to increase? Is it LDH2 or LDH1? It is the LDH1 because it is the LDH2 because in the RBC we have the LDH2. So if there is a hemolytic anemia, the LDH2 is going to increase. Then the next is the stress test, the treadmill test. We tell the patient to walk on the treadmill to find out that whether the patient is able to tolerate the heart rate or not, right? And what protocol we are going to use is the Bruce protocol. And according to Bruce protocol, the target heart rate is 220 minus age. If the patient's age is 40 years, then the target heart rate is 180. And while he is walking, we will regularly monitor the ECG. On the ECG, if we are able to see the ST depression, which is of 2 mm deep, 2 mm wide in 2 leads, it is significant, and we'll say that the TMT is positive. And then we will calculate a score that is called as DOAC score. Later on, we will discuss about the DOAC criteria. The DOAC criteria that is there in the infective endocarditis. Can you tell me that the DOAC staging is used for what? DOAC staging, it is used in the rectal cancer, the colon cancer or the colorectal cancer. We are going to use the DOAC staging. When we do the echocardiography, we want to see that the entire right ventricle, left ventricle, they are contracting or not. If some area is not contracting, that is called as RWMA. And whether that, for example, here is the left ventricle and it should contract like this. If there is one area which is not contracting, then we have to find out whether this area is alive or dead, jinda hai ki mar gaya. The best viability test is going to be PET scan. When it comes to PCI, percutaneous coronary intervention, in that we do the angiography and angioplasty. Angiography is an investigation to find out that where is the blockage, and angioplasty is basically the stent placement. Then one more thing that we do for the management is CABG, bypass. I want to tell you one question here. They will ask like this: which blood vessels can be used for the graft? When we do the coronary artery bypass, which vessels can be used for grafting? For grafting, this is going to be an all except question. All of the vessels are used for grafting except there are 3 vessels which are used. That is the, yes, it is the internal memory artery, it is the great saphenous vein, and radial artery. Internal memory, great saphenous, and radial artery. So it's a all except question. Then if they ask that what is the indication that when to put the stent, when to put the bypass, if a person is having triple vessel disease, TVD, or if there is the blockage is in the LMCA, if the LMCA is blocked, or the proximal area of the LAD is blocked, proximal LAD blockage, or the bifurcation area is blocked, triple vessel disease, LMCA blockage, proximal LAD blockage, will go for bypass, will not put the stent. Then comes the complications of myocardial infarction. Complication of MI. When it comes to complication, first to identify which areas are there to find out the murmurs. This was a very important diagram. wherever I am putting the question mark, make sure that the next 3 4 hours when we are having this discussion, be very attentive. And whenever I put a question mark, you should be prompt enough to remember the things here itself in the session, because we don't have much time till the exam. So let's be more focused for at least next 3 4 hours. So the areas which is very likely to be tested, हम यहीं पे याद करके खत्म कर देंगे. ऐसा नहीं है कि we will not see it again or will not read the PDF again, but let's make sure that for the next 3 4 hours we are so attentive. Now, when it comes to the areas of auscultation in the heart, we are having 4 valves, so we have identified 4 areas for auscultation. For example, here is on the right side, second intercostal space, it is the aortic area. Left side, second intercostal space, pulmonary area. Fourth intercostal space is going to be the tricuspid area. And the left ventricle apex, somewhere in the fifth intercostal space, it is going to be the mitral area. So they give you this diagram and they ask you that what is the name of these areas. Then what are the complications that happens? If they say that the patient has developed myocardial infarction and coming to you, then you have to see that the patient is coming within how many times. If the patient is coming within few hours, the patient is dead. Within the few hours of myocardial infarction, the patient is dead. The diagnosis is ventricular arrhythmia. If the patient is coming within few days, the patient has developed myocardial infarction on 15th of December and he is coming after 3 days, 4 days, 5 days. And what is the problem is there is a sudden decrease in the blood pressure. If this is mentioned in the question, it is going towards free wall rupture. If after few days of myocardial infarction, there is a new murmur. Earlier, there was no murmur in the patient, but after myocardial infarction, 3 4 days, there was a new murmur. Then you have to see where the murmur is at the mitral area or the murmur is on the left sternal border. If the murmur is in the mitral area, the answer is going to be the acute mitral regurgitation. If the murmur is in the left sternal border, the answer is it is the ventricular septal rupture. I am just telling you the main buzzword, right? It is not a time that where we'll discuss the entire concepts. I will try to keep the things very straightforward. If this word you see, that is going to be the answer. And this is how it has to be revised now at this particular juncture. Then if the patient comes within few weeks of myocardial infarction and the patient is having the chest pain, means the patient is having the Dressler syndrome. One more thing, I'm having some space here, so I will be, okay, let me add one page here. Okay, here I'm having some space. So when it comes to the management, in the coronary artery disease, if they say stable angina, there are 4 drugs to be given. Beta blocker, nitrate. Beta blocker is going to decrease the heart rate. Nitrate is going to increase the supply. Statin is going to stable the plaque, and aspirin is an antiplatelet drug. If there is unstable angina or NSTEMI, the treatment for USA and NSTEMI is exactly same. We are going to give these 4 drugs: beta blocker, nitrate, statin, aspirin. ये तो देना ही देना है. We'll give these 4 drugs. Along with that, we will add one more antiplatelet drug, that is clopidogrel, plus we'll give low molecular weight heparin. So these are the 2 additional drugs that we are going to add. When it comes to STEMI, the treatment of STEMI and NSTEMI is going to be exactly same. We are going to do all these things, but along with that, we will do 2 more things. One, either we'll go for primary PCI, that is angiography, angioplasty, or we will go for thrombolysis. Thrombolysis. If they ask which is better, PCI is any day better than thrombolysis. And in the thrombolysis, even if you do thrombolysis, after that also you have to go for the PCI. And if they say the thrombolysis was successful, means the patient chest pain has subsided after the thrombolysis, then still you are doing the PCI, that is called as check PCI. And after Unsuccessful thrombolysis, if you are doing PCI, it is called as rescue PCI. Rescue PCI. This is all about the coronary artery disease. The next chapter is jugular vein pressure. When it comes to the JVP, the few points first about the JVP part. JVP is basically is a pressure of right atrium. It is a right atrial pressure. The place where we measure the JVP is going to be the right internal jugular vein. What is the normal JVP? The normal JVP is going to be the normal right atrial pressure, that is 2 to 5 millimeter of mercury. If you want to convert into centimeter of water, that is 5 to 8 centimeter of water. This is the normal JVP. When it comes to the question that they mainly ask about the JVP, in the JVP we are having 5 waves, A, C, V, X and Y. But they ask that what happens with the JVP in cardiac tamponade and constrictive pericarditis, particularly X and Y. X is going to be prominent in both of them. Whether it is cardiac tamponade or constrictive pericarditis, X is going to be prominent. But in cardiac tamponade, the Y is going to be absent, whereas in constrictive pericarditis, Y is also prominent. And this is your two-time question. What happens with the Y in cardiac tamponade? In cardiac tamponade, in the JVP, the Y wave is going to be absent. When it comes to the prominent Y, this prominent Y is also referred as Friedrich sign. Prominent Y is called as the Friedrich sign. What happens with the Y in tricuspid stenosis? In tricuspid stenosis, the Y wave is going to be absent or it is going to be very diminished. And in the TR, it is going to be prominent. If a question comes that so and so wave is seen in which disorder, and if you don't know any answer from the JVP, if the question comes that this particular wave or this particular problem is seen in which condition, if you don't know the answer, go for tricuspid regurgitation. Because in tricuspid regurgitation, we have many findings. In tricuspid regurgitation, we are going to have the CV wave. In tricuspid regurgitation, we are going to have the prominent Y. We are going to have absent X. So a lot of finding, a large V wave. So a lot of finding is there in TR. What is Kussmaul sign? Kussmaul sign is basically normally whatever is my JVP. For example, my JVP is, let's say right now 5. If I do inspiration and I hold my breath, my JVP is, whenever I will do the inspiration, the JVP is going to decrease normally. So normally on inspiration, the JVP should decrease. But if it is not decreasing, rather it is increasing, then the answer is going to be Kussmaul. Then this is called as the Kussmaul sign, and it is seen in many conditions. It is seen in constrictive pericarditis. It is seen in RVMI, restrictive cardiomyopathy, many conditions. But what is more important, Kussmaul is not seen in. Kussmaul is not seen in cardiac tamponade. Not seen in cardiac tamponade. So 4 questions from JVP. First, and the most important, what happens with Y wave in the cardiac tamponade? The Y wave is going to be absent. Second, the JVP is measured in which area? Right internal jugular vein, the normal JVP 5 to 8. If you don't know any answer from the JVP and they ask that this particular wave is seen in which condition, if you don't know the answer, go for tricuspid regurgitation. The 4th question, Kussmaul sign is not seen in which condition? It is not seen in cardiac tamponade. The Kussmaul sign should not be confused with the Kussmaul breathing. What is Kussmaul breathing is, Kussmaul breathing, it is seen in metabolic acidosis. What is the meaning of Kussmaul breathing? For example, here is the representation of the blood. In the blood, we are having the 2 types of acid we have in the blood. One is carbon dioxide and second is H+. We always want to remove the acid from our blood. To remove the carbon dioxide, we have the lungs, and to remove the acid, we have the kidney to remove the H+. But by any chance, if the kidneys are not working, there is a damage in the kidney, then this H+ is going to increase. And the moment this will happen, this is referred as metabolic acidosis. And because of that, the pH will go towards the acidic side. But your body does not want this to happen. So what your body will do, because the acid is increasing, the H plus is increasing, but we don't want to increase, we don't want to disturb the pH. So the body will try to compensate and will try to throw this acid more out from the body. And how to throw out at least this acid, because the body will say that कि यार इसको बाहर नहीं फेंक पा रहे, we are not able to throw the H plus, let's throw the carbon dioxide more out. And for that the patient is going to breathe very fast and deep, and this is called as the Kussmaul breathing. And this Kussmaul breathing is going to lead to CO2 washout. It will lead to CO2 washout. Whenever now let's finish the ABG here itself. Let's complete the ABG here itself. Whenever a question on ABG will come, I will tell you one very simple algorithm that you should follow. First, check the pH of the blood, whether it is less than 7.35 or is it more than 4.5. So first thing first, I will try to see that where is the pH. Is it less than, the pH is less than 3.5 or the pH is more than 7.45, means acidosis or alkalosis. If the pH is normal, if the pH is normal in between, then we'll say that it is a compensated condition. If the pH is in the normal, means 3.4, 3.5 to 4.5, then it is compensated. But if it is less than that, it is going towards acidosis. If it is more, it is alkalosis. Then we have to find whether it is metabolic or respiratory. For that, we will check the carbon dioxide and bicarbonate. Only two more parameters you are going to check in the ABG. One, you will check the carbon dioxide. The normal carbon dioxide is 35 to 45. If the carbon dioxide is more, it is referred as respiratory acidosis, because the carbon dioxide is a respiratory molecule and it is acidic in nature. So if it is more, it is called as respiratory acidosis. If the carbon dioxide is less in the blood, if the acid is less, then it is called as respiratory alkalosis. In the same way, the next thing you will check is the bicarbonate. 22 to 26 is the normal. Bicarbonate is a metabolic molecule and it is alkaline in nature. If the bicarbonate is more, if the alkaline molecule is more, it is referred as metabolic alkalosis. If the bicarbonate is less, it is called as metabolic acidosis. Metabolic acidosis. Then there are some buzzwords. For example, if they use the word anion gap, maybe in the questions or maybe in the options, if you see the word anion gap, either it is mentioned in the question stem that we have taken the sample and the anion gap is disturbed, or somewhere if you see the anion gap word, then try to find that the anion gap is normal or increased. If the anion gap is normal, this is called as NAGMA, normal anion gap metabolic acidosis. If the anion gap is high, it is referred as HAGMA, high anion gap metabolic acidosis. High anion gap metabolic acidosis is seen in many conditions. You don't have to remember all the names. But NAGMA is only seen in 3 conditions, and the mnemonic is red. The dress is red. R stands for renal tubular acidosis. E stands for early CKD and diarrhea. Early CKD and diarrhea. The moment you see the word anion gap, most likely the answer is metabolic acidosis. It may be NAGMA, it may be HAGMA. HAGMA is seen in many conditions. Any poisoning. One more hint. Now I'm writing few hints for your exam. If they write some poisoning and they ask that what is the diagnosis in the ABG, the diagnosis is HAGMA. Any poisoning they write, methanol poisoning, ethanol poisoning, salicylate poisoning, any poisoning, the answer is HAGMA, high anion gap metabolic acidosis. If they write the word vomiting, if a person is having a lot of vomiting, the acid will go out. If all the acid will go out inside, there is very less acid, the patient is going to develop alkalosis, metabolic alkalosis. If a person goes to, now they can ask like this, the patient has went to the mountains for trekking. If the patient will go to the mountains on trekking, you have seen that on the mountains we breathe very fast. If there is increase in the respiratory rate, the CO2 will wash out. The moment CO2 washout will happen, the carbon dioxide goes out. Carbon dioxide is the acid. If the acid goes out, what will happen inside? There's going to be alkalosis. So CO2 washout will lead to respiratory alkalosis. So these are some of the hints that is there. If they want to ask you a very difficult question from ABG, they can ask about winter formula. What is winter formula is? Winter formula ये बताता है that what should be the normal carbon dioxide. I already told you that the normal carbon dioxide should be 35 to 45, but for individuals, we should have a precise, customized new normal range of carbon dioxide. मतलब कि normally तो हम carbon dioxide we say 35 to 45 it is normal, but the Winter says no. For every individual, it has a different range and it is calculated by Winter's formula. How to calculate is 1.5 into the bicarbonate of the patient plus 8 plus minus 2. Now let me finish all the formulas here itself. One more formula that you should remember is what is total cholesterol. Total cholesterol is LDL plus HDL plus 1/5 of triglyceride. Sometimes in between the topic, I may go here and there a little of bit. I will not go here and there a lot so that there will not be mixing of the data, but slightly here and there because one formula came. So I told you one more formula that is to be remembered, right? So that we will not miss out because right now, whatever related thing will come in my mind, I will at the same time, I will let you know about that particular part. The next topic we are discussing is rheumatic fever. Rheumatic fever, it's male or female, it is going to have the equal prevalence. It is going to happen in the pediatric age group. It is caused by Streptococcus pyogenes. It is the group A beta hemolytic Streptococcus. There is a child, his name is Bolu. Bolu is having the recurrent tendency of developing the throat infection. Any recurrent infection is happening. And whenever any infection happens, the immune system is going to make the antibodies to kill the infection, right? So the antibodies was made, and these antibodies were made against the M protein of the bacteria. Now, so far it looks fine that here is the bacteria, and to kill that, we are making the antibodies. But these antibodies, they can cross-react with one molecule called as NAG. These antibodies gets confused. They were supposed to kill the M protein, but they start killing the NAG molecules also. And the NAG molecules are found in 5 places. They are found in heart, joints, neurons, skin, and subcutaneous tissue. So these antibody can damage any of these tissues, and that is called as the rheumatic fever. Most commonly, these antibodies are going to affect the heart and joint. In the heart, mostly they are going to affect the innermost layer of the heart, that is endocardium, and the endocardium of the mitral valve will be damaged. And because of that, we might see a murmur called as the K-Tecum's murmur. These antibodies will attack the joints, and because of that, the patient is going to have the joint pain. It may be monoarthritis, monoarthralgia, polyarthralgia, or migratory polyarthritis. The neurons can be damaged. If the neurons is damaged, it is a rare finding and it is a late finding. Rare and late manifestation is syndrome scoria. Skin finding is erythema marginatum. On the skin, there is going to be ring-shaped rashes are there, that is erythema marginatum. Subcutaneous nodules can be there on the extensor surface. So any of these symptoms will be there. How to confirm rheumatic fever? First, we have to find that the child has developed streptococcus infection. To confirm that, we can do a throat swab culture. We can check ASO titers. The ASO will be more. Anti-DNase antibody, rapid antigen test. We can do any of the one. But any one has to be positive. You first have to find the evidence of streptococcus. Then you are going to use a criteria called as Jones criteria. In the Jones, there are 5 major and 4 minor. The Jones, the mnemonic is Jones itself. J stands for the joint involvement, carditis, neuronal involvement, that is the chorea. E stands for erythema marginatum, and subcutaneous nodules. So if you find the evidence, you find some major feature, you find some minor feature, then you can make a diagnosis of rheumatic fever. There are 2 questions I want to tell you from the treatment part, very important. Rheumatic fever patient, if it presents with joint pain, If the rheumatic fever child is presenting with the joint pain, we are going to give him aspirin. For the joint pain, we'll give him aspirin. Then we don't want the recurrent infection to occur in the throat. So for prophylaxis, we need to give the antibiotic. And the antibiotic that we are going to give is injection of benzathine penicillin. Injection of benzathine penicillin we will give. Plus one question which has been asked 2 years back, very difficult question. I will just directly tell you the question. If they say that in which of the clinical feature of rheumatic fever the parents will not give the history of fever, in which of the following thing in rheumatic the the parents will not say that the immediate history of fever was there. Means what happens is, for example, if a person is going to develop rheumatic fever, he will develop the throat infection and then he will develop any of these symptoms, and these two symptoms occurs very early just after the fever. But the neuronal symptoms, the chorea, is going to happen very late. So let us write down this statement directly. In chorea, there is no history of immediate fever. No history of immediate fever. Then there are similar words. I want to write down them together here. For example, we have discussed about migratory polyarthritis. Migratory polyarthritis means one joint is having inflammation, then another, then another, then another. It is seen in rheumatic fever. Erythema marginatum, it is seen in rheumatic fever. But if they say necrolytic erythema migrans, can you tell me this? Necrolytic erythema migrans, it is seen in which condition? Necrolytic erythema migrans, it is seen in glucagonoma. So these are some of the similar words to be remembered. The next we are discussing is the infective endocarditis. Infective endocarditis, it is the infection of the endocardium. The most common cause is going to be Staph aureus. Mostly it is going to be a hospital-acquired infection, and the most common cause is Staph aureus. There are some other causes are also there, such as Enterococcus, Enterococcus faecalis. If they say that the patient is having a colon cancer and now he has developed infective endocarditis, in a colon cancer patient, infective endocarditis, it is the Streptococcus bovis, also called as the Galolyticus, Streptococcus bovis or Galolyticus. If an IV drug abuser is there, there is a person who is taking the narcotics, he is an IV drug abuser, and now he has developed the infective endocarditis, then the answer is going to be Staph aureus. Because what happens is on the skin, we have a lot of Staph aureus, and those who take the IV drugs, they don't clean their skin, they puncture the needle, Staph aureus goes inside their blood and will reach to the heart. And all the venous blood is going to the right atria, so the Staph aureus will reach in the right atria, then it will cross the tricuspid valve and it is going to attach on the tricuspid valve. So there is going to be the tricuspid valve involvement is very common. Then if they use the word catheters, if a person is having UTI, the catheter is there and now he has developed infection in the heart, then the answer is Enterococcus faecalis. If the UTI word is mentioned or the catheter word is mentioned, then the answer is Enterococcus faecalis. How they will ask the question, the hint will be like this. They will say that mostly it is going to be a young female. She is having some pre-existing cardiac disease. Pre-existing cardiac disease such as the mitral regurgitation or mitral stenosis or somewhat like this. She went to a dentist, some dental procedure was done, some dental surgery was done, and after that she is having high grade of fever. Along with the high grade of fever, there is splenomegaly is there. High grade of fever, splenomegaly in a pre-existing cardiac patient, then it is going to worsen infective endocarditis. To diagnose this, we will use a criteria that is called as the Dux criteria. In the Dux criteria, we have the major and the minor ones. In the major, they ask that one of the major criteria is blood culture. They ask that how you take the blood culture, minimum how many sets of blood culture you will take. We are going to take minimum 3 sets of blood culture, and in each set there will be 2 bottles. There is going to be one aerobic bottle and one anaerobic bottle. This is what is written in Harrison, but the American Heart Association says different. The American Heart Association says that we are going to take 3 sets, but I am writing American Heart Association. If this answer is not there in the exam, one aerobic, one anaerobic, then the second best answer is going to be one aerobic, two anaerobic. We'll go with this. Then in the infective endocarditis, we are going to have some phenomena called as the vascular phenomena and immunological phenomena. Vascular and immunological phenomena. The vascular phenomena are many. We don't have to remember them. But the immunological phenomena, the mnemonic for that is either two. You can use this mnemonic GORI. GORI is the immunological phenomena. I for immunological phenomena. G stands for glomerulonephritis, Osler node, and Roth sport. Roth sport. This is the immunological phenomena. The infective endocarditis, sometimes in the infective endocarditis, there is going to be false positive RF factor. RF factor can be false positive. Normally, the RF factor is positive in rheumatoid arthritis, but it is also positive in infective endocarditis. The treatment is simple. We have to give antibiotic. It's an infection in the heart. So we'll give the antibiotic, and we have to give a prolonged course of antibiotic to treat this condition. This is all about the infective endocarditis. The next is the aortic regurgitation. When it comes to aortic regurgitation means when the left ventricle is contracting. Normally, when the left ventricle contracts, it is going to eject the blood normally in the aorta like this. Normally, when the left ventricle contracts, we eject the blood in the aorta like this. But just a second. And during the diastole, the aorta is going to contract, and this blood is supposed to go forward. It should not come back. Normally, the blood is not coming back, but if the aortic valve is not closed properly, the blood will regurgitate back, and this is called as aortic regurgitation. So aortic regurgitation is a problem of diastole. During the systole, the left ventricle contracts and the blood is going in the aorta, no problem. But during the diastole, the aortic valve was supposed to be closed, but it is not closing, so the blood is regurgitating back. It is called as the aortic regurgitation. The most common cause of aortic regurgitation is going to be the rheumatic heart disease. The important finding is the named pulses. There are many named signs are there. In aortic regurgitation, the blood goes up and it comes back. So when the blood goes up, the head becomes heavy. So there's going to be movement in the head. There's movement in the carotids. So the movement in the carotid is called as carotid dance or the water hammer pulse. The movement in the head is called as the Dewey-Musset sign. The movement in the uvula will be there. That is called as the Muller sign. If you put the stat on the femoral artery, this is very important. If you put the stat on the femoral artery, there is going to be a murmur called as the Durozius sign. And if you press the stat, if you just put on the femoral artery, there will be a sound. Grrr, grrr. This sound is there, that is Durozius sound. But if you press the stat, then the sound will change. This sound will be coming. This is the pistol-like sound, and this is called as Straube sign. In the aortic regurgitation, we can see the capillary pulsations also, that is the called as Quincke's sign. So there are many named signs are there. So by any chance, if a question comes and they say that XYZ sign is seen in which condition, the options are MR, MS, AS, ASD, VSD. If such options are there, always, if you don't know the answer, go for AR, because most of the named signs are seen in AR. Most of the named signs are seen in AR. Then coming to the next one, that is the The Hill sign in the patient of aortic regurgitation, the lower limb pressure is more. Can you tell me a condition where the lower limb pressure is less and the upper limb pressure is more? If they say in the upper limb, the pressure is more, and in the lower limb, the pressure is less. If this combination is given, this is seen in coarctation of aorta. And the coarctation of aorta, it is seen in what? It is seen in Turner syndrome. Turner syndrome is 45XO. If they say a patient is presenting with us and he is having the tearing type of chest pain in the interscapular area, on the between the scapula, the patient is having the tearing type of chest pain. The moment we'll see this word, it is aortic dissection. It is basically there is a problem in the wall of aorta. It's not made up of good connective tissue, so it may rupture. It is seen in Marfan syndrome, Ehlers-Danlos syndrome. Along with that, in this aortic dissection, the blood pressure in the right and the left upper limb is not going to be the same. On the MRI, we are going to have a very peculiar appearance called as the tennis ball appearance. To see where is the aortic dissection, is it in the ascending aorta or descending aorta, we use a classification called as Stanford classification. If it is in the ascending aorta, it is called as the type A. It is going to be called as the type A dissection of aorta. If it is in the descending aorta, it is called as type B. What question they ask is how to manage the type A and type B. For type A, we will have to go for surgery, and for type B, B for BP control. For type B, we will go for BP control, we'll give the IV drugs. But in the dissection of aorta, the problem is there is one more classification is there, that is called as the DeBakay's classification. Now, what this classification is going to tell to us is basically in the Stanford, that is only two category, either the problem in the ascending aorta or the descending aorta. But if the problem is extensive, then we have made new classification DeBakay, that is type 1, 2, 3. In 1, there is going to be problem in ascending and descending both, then the type 2, and then the type 3. But generally, they don't ask about this classification. What they ask is how to manage. The type A, we will do surgery, and type B, B for BP control. For that, we'll give the intravenous drugs to decrease the blood pressure. Then coming to the ECG part. In the ECG, first, the normal durations of the wave. When it comes to normal duration, for that, always remember one small box is equal to 40 milliseconds. So we will never remember the milliseconds, we'll always remember the small box. And we can anytime we can convert into millisecond by multiplying into 40. The mnemonic is very simple. QQR, PPR. QQR, PPR, TQT. QQR, PPR, TQT. 1, 2, 3, 4, 5, 10. The Q wave should be less than one small box. The QRS should be 2 to 2.5. The P wave should be less than 3 small box. The PR interval should be 4 small box. The T wave should be less than 5 small box. And the QT interval should be 10 small box. So 1, 2, 3, 4, 5, 10, QQR, PPR, TQT. Now, because the PR and the QT, they are intervals, so there has to be a range. And if I make a range here, because I have written 4, so the range will be 3 to 5. And here the range will be 9 to 11. So this is how we remember the normal duration of the waves. One of the important ECG that they ask in the exam is heart blocks. Heart block means there is damage to AV node. Whenever there is damage to AV node, it is referred as heart block. Because of that, there can be two types of problems can happen in the ECG. Either there will be a drop beat or there is going to be prolonged PR. So we have to see which type of finding is there. Now we understand that damage to the AV node is called as heart block, but how much is the damage? Mild damage, moderate damage, severe damage. Based on that, we have three types of heart block: first degree, second degree, third degree. If a ECG is given, always make sure that first you are looking at the options, not the ECG. First, always look at the option, because the options will tell you where to see, what to see, right? So we will go to the options, and if the options are saying first degree heart block, Morbitz 1, Morbitz 2, if these options are given, then yes, we will go to the second lead, and first thing first, we'll try to find the drop beat. What is the meaning of drop beat? Normally, after every P wave, the QRS should be there, like this. But if after the P wave there is no QRS is coming, and then again the P wave is coming, then this particular thing is referred as the drop beat. So first thing first, I will try to find the drop beat. If there is no drop beat and it is a question of heart block, because the options are saying heart block, if there is no drop beat, the answer is going to be first degree heart block. But if the drop beat is there, then it may be Mobitz 1, Mobitz 2. Then you have to see that the PR interval is same or changing. If the PR interval is same, the answer is Mobitz second. Mobitz second may, the drop beat is there, but the PR interval is same. If the PR interval is not same, it is Mobitz 1. The Mobitz 1 is also referred as Wenckebach phenomenon. It's also referred as Wenckebach phenomenon. In third degree, there is no relation between the P and QRS. The P is coming on its own, the QRS is coming on its own, there is no relation. When it comes to treatment, the first degree and Mobitz 1, nothing to be done, just wait and watch. And for the Mobitz second and third degree heart block, we'll go for pacemakers. Now, because in the heart block, there is damage to the AV node. So what is happening is the current is not able to go from the atria to ventricles, right? And because of that, that is why we were having the drop beats. So by any chance, if a very peculiar pattern is happening, that after every 2 P wave, 1 QRS is coming. If you take out the ratio of P and QRS, it is coming out to be 2:1. That is called as the 2:1 block, that every alternate P is getting dropped. These are the drop beats. These are the drop beats. It is kind of a morbid second block only, but we have given a special name. It is called as the 2:1 block. 2:1 block. Then in the ECG, one question from WPW syndrome. It is going to be all except question. All of the following are seen in WPW syndrome except. So what is not seen? What is not seen? It is prolonged PR. In WPW syndrome, the PR interval is going to be short. In WPW syndrome, the PR interval is going to be short because in WPW syndrome, there is an accessory pathway. So the current goes very early to the ventricles. So the PR interval will be less. In WPW syndrome, the prolonged PR is not seen. Then one more question is that when it comes to the treatment part of WPW syndrome, what is the best treatment? The best treatment is remove the accessory pathway. That is the radiofrequency ablation of the accessory pathway. Radiofrequency ablation. Then comes the pulmonary embolism. There are two questions from the ECG of pulmonary embolism. What is the most common change? Can you tell me what is the most common change and the most specific change? The most common change of pulmonary embolism in the ECG, it is going to be sinus tachycardia. The heart rate is going to increase. Sinus tachycardia is the most common change. If they say most specific change, then it is going to be S1Q3T3 pattern. S1Q3T3. And in the S1Q3T3 also, if they particularly ask which is most specific among these three, the answer is T3. This is the most specific. Among the three, the most specific is the T3. In the third lead, the T wave is inverted. Then how to diagnose the different types of arrhythmia and how to deliver the DC shock. This is one question which I am definitely very strongly recommending everyone listen it very carefully. It's very likely to be asked. Listen it. If you see an image of ECG and they have mentioned that the blood pressure is 60/40 or 80/40, if ECG image is given and the blood pressure is very less, the moment you see means, because what they want to ask you is actually the patient is having some type of arrhythmia, and in arrhythmia we can have decrease in the blood pressure. Whenever the arrhythmia is decreasing the blood pressure, any arrhythmia, whatever is the name, whether it is PSVT, VT or any arrhythmia, decrease in the blood pressure, immediate treatment is DC shock. There are two types of DC shock, synchronized and non-synchronized. The synchronized is also called as cardioversion, non-synchronized is called as defibrillation. Generally, we try to give synchronized. If you can't give synchronized, then we'll go for non-synchronized. So, but the take-home message is very simple. Any ECG image, the blood pressure is less, the treatment is DC shock. Maybe cardioversion, maybe defibrillation. They will not give you both the choice, and mostly they will give you the choice cardioversion. Select the word cardioversion. Select the word cardioversion. One more question from ECG. They may give you the image of ECG, they may not give you, but if they write the word irregular RR interval, the moment you see this word, the answer is atrial fibrillation in your exam. It is very simple. Irregular, the answer is atrial fibrillation. If you see the sawtooth pattern, which unlikely to be asked, it is atrial flutter, which is very easy. In COPD patient, if they say a COPD patient is having palpitation after starting a new medication, COPD patient को एक नया दवाई चालू किया, a new drug was started, and then he is developing palpitation, the answer is MAT. How to find out MAT? In the second lead, you will be able to see more than 3 shapes of P wave. If they say a young female presenting with palpitation, impending doom, and you will see that the ECG is looking like this. The QRS is very narrow, like this. If you see the ECG in a young female with palpitation, what you can observe is after the R wave, you can see the wave is the T wave. Then again the R wave, then is the T wave. So between the two R's, you can see only one wave, that is T. Normally between the two R wave, you should have the P and T, but यहाँ पे there is no P wave. If there is no P wave, the answer is PSVT. The answer is PSVT. No P, the answer is PSVT. Ventricular tachycardia, they don't give you the ECG for the diagnosis, but if they ask what is the diagnostic criteria, yes, more than 3 VPCs continuously, heart rate more than 100, QRS more than 100. It can be monomorphic, can be polymorphic. The polymorphic is also called as torsades de pontis, and the ECG looks like this. As if the ECG is rotating around the axis, it's called as TDP. The question that is going to come on the PSVT, which I am strongly feeling that this question can come, the question will be, what is the prophylactic drug for the prophylaxis? Which drug is to be given? And the first option will be adenosine. Adenosine we don't give for prophylaxis, right? You all know that adenosine is for the acute management. If the patient is presenting with acute attack of PSVT, we'll give adenosine. That is fine, but they will not ask this. They will ask the prophylactic drug, that is diltiazem. Diltiazem. One question from the pediatrics that has been asked earlier: what is the dose of adenosine in the pediatric age group? It is 0.1 milligram per kilogram. In the pediatric age group, 0.1 milligram per kilogram, right? So these are some of the important questions from the ECG. I'm just revising 5 questions from ECG. If you have not touched the ECG, no problem. No problem. Remember these 5 questions. First, if you see a ECG image and the blood pressure is decreasing, the answer is cardioversion. Give DC shock because the BP is less. You have to treat the arrhythmia immediately. Second question, if there is irregular RR interval, go for atrial fibrillation. Whether the image is given or just the words are written in the question, irregular, it is going to be atrial fibrillation. COPD patient, after starting a new medication, the patient is having palpitation, the answer is MAT. Young female, palpitation, and the ECG is looking like this. They will ask, what is the prophylactic drug of choice? Then the answer is diltiazem, not the adenosine. It is diltiazem for prophylaxis, right? So these are the 4-5 questions to be remembered from the ECG part. Now here itself, I also want to mention one point here is, see, when in these 30 days, when you will be revising your notes, there will be some parts in some subjects where you will not be feeling good. Your speed will be very slow. हम क्या होता है कि in these 30 days, we want to be very aggressive actually. But on contrary, your speed is relatively less. If you compare your speed, which was there 1 month back, 2 months back, 3 months back, your speed was much faster. And right now, the speed has become slow. And we feel very distressed because of that. We were thinking that कि last में तो जल्दी जल्दी पढ़ लेंगे, but उल्टा हो जाता है. It becomes reverse. It's a very normal phenomena to happen. If it is happening with you, don't worry. It happens with everyone. Because the reason for that is we become overconscious while revising the notes. Plus, we start thinking about the results, not results, rather, I would say that you start thinking that on 16th of January, by 16th of January, whether you will be able to finish all the things or not. हम ये सोचने लग जाते हैं. And the more this thought will come, the more the lag will happen in our reading, And the moment we lose the momentum for just for 5 minutes, immediately your brain will give a signal that this workbook is not working for you. Let's find a shorter way कि कम जगह से पढ़ लेते हैं यार, ये तो नहीं हो पाएगा, कम से कर लेते, वहां से कर लेते, यहां से कर लेते. Don't give your brain the time, because you guys know that it is not the time to change the source, right? So whatever you have did, let's continue with the same. Don't give your brain the time to think कि मैं नहीं हो रहा है तो कैसे करना है इसको. फॉर एग्जाम्पल, आई एम रीडिंग ईसीजी, मेरे को समझ में ही नहीं आ रहा, आई एम नॉट एबल टू डू, एंड आई एम स्टक हियर एंड देयर, नॉट एबल टू रिवाइज. नो, I will just close this chapter and I will just see what is the most important 5 or 10 statement which the teacher has told from that topic. And I will just try to keep that in the mind and I will just skip that part. No worries. You can't be perfect in all the 19 subjects equally. Accept that fact. It is not, actually, it's not mandatory to be equally good in all 19 subjects to pass the exam. To pass the exam, I would preferably say that the first half is going to be very crucial for you, because that is going to give you a numerical win as well as a mental win. Why numerical win? Because if you see in the first half, the majority of the question is going, the subject, there's going to be overlap, but still, the first half is going to be anatomy, biochemistry, physio, patho, pharma, FSM, PSM, and some gynae. Mostly these subjects are going to come in the first half, some here and there. Now, if you find out of these total, I have written 8 subjects, but out of 8, if you are able to be good in 6 subjects, forget about 19 subjects, forget about 19. If you are good in 6 subjects out of these 8, and these 2 must have to be there, these 2 giants has to be there. And I think that most of you are good in PSM, most of you are good in gynae. I don't know for what reason, but सबको gynae PSM अच्छा ही लगता है. You may not like biochem, you may not like anatomy, micro, but you are good in that. So out of these 9 subjects, if you are good in 6 subjects, it's good. What is the definition of good for me is, from whichever source you have did, if the question will come from those workbooks and it can't go wrong, bahar se aayega to galat hoga, it's okay. But if you're confident, if the question will come from the workbook, it will not go wrong, you are sorted. Aap pass ho exam, you are already cleared the exam. Why? Because if you see, let's say there is one student who is good in PSM, gynae, or let's say FSM also, let's say maybe patho, maybe pharma, or maybe one more subject, let's say biochem. Any 6 subject, including PSM and gynae, any 6 subject, it is going to give you almost around 120 marks in the exam, 110, 120. And out of 120, let's assume that 100 question has came from the notes. 20 question notes के बाहर से आए, तो आप सही नहीं कर सकते थे. But because you are very good in these 6 workbooks at least, so out of that 120, 20 question was out of the notes, no problem. Out of 100, at least you will secure 90. इतना अच्छा पढ़ के जाएंगे यार, 90 तो करेंगे ना यार 100 में से, राइट. द रिमेनिंग 30 क्वेश्चन जो यहाँ से आएंगे here and there, उसमें भी you will get maybe 5 marks, 10 marks, somewhat you are going to get here, let's say 10 marks. So cumulatively, if I am going to get 100, 110 in the first half itself, just imagine, in the first half, if someone gets 110 marks, he's already sorted, because he's going to have a lot of confidence in the second half. मैं already pass हुआ, मेरे को 110 marks वैसे ही आ गए. In the second half, in 150 question, I have to secure just 40 marks. It's not going to be a difficult task. ऐसे ही आ जाएंगे 40 marks तो यार, right? So make sure that you are, because अगर first half किसी का खराब है, if you are weak in the first half, if you are not good in patho, pharma, micro, physio, biochem, then you will lose the confidence for the second half. You may not have the control on your nerves for the second half. So be mentally prepared. But right now, if you are thinking, ki, sir, then I am very weak in pharma, I am very weak in micro, I am very weak in patho, what should I do now? Now, it is not the time that we try to make it very strong now. So then you have to accept that fact that the first half मेरा थोड़ा सा ऊपर नीचे होगा, because I have not prepared. I will take care in the second half. That mental preparation has to be done in advance. If you have not done these 5-6 subjects, then let's have a mental preparation, and then it will be done. But make sure that 6-7 subjects you are super nice and you are sorted. The other subjects you read multiple times, बार बार पढ़ेंगे और आराम से हो जाएगा, right? And ultimately time है, निकल ही जाएगा. See, these 30 days will also pass, right? Right now it may feel कि कभी कभी तो ऐसा लगता होगा यार, take my exam tomorrow और खत्म करो इस झंझट को. I don't want to take it further. Let's finish it. Let's do this. Let's do that, right? This time will pass by. On 16, 17, every one of you will feel कि यार 2 दिन और मिल जाते. I would have revised PSM again. I would have revised that again, right? So that time is actually here. That time is here right now. Don't have that thoughts कि कितना खत्म होगा. एक दिमाग से एक क्लॉट निकालो पहला. Second clot you need to remove is your GT score. Some of you are getting very good GT score. Some of you are getting the GT score of 130, 140, 150. It doesn't matter at all. ये बिल्कुल काम नहीं करता. एक ही चीज काम करती है कि whether you are making the easy questions correct or not. Everyone who is sitting in this classroom right now, there are around 700 students are there. Everyone has prepared decent enough to clear this exam. सबको इतना आता है कि आप एग्जाम क्लियर कर लोगे, provided that you don't do a silly mistakes there. And why we do silly mistake is because of the nervousness, because of over anxiety, because of overthinking. So let's take out that clot of the mind that I am just getting my GT score is stuck at 150, my GT score is stuck at 170. What is going to happen? Plus minus 20 is going to happen, plus minus 30. There is no such formula, guys. Whoever is saying there is no such formula, ऐसा कोई formula नहीं होता है. ये सब बोलने की बातें होती है. काम केवल एक ही चीज आती है कि हमें जो आता है हम वो सही कर दें, बस. आप इतना करके आ गए ना, जितना आपको आ जाता है ना, ये भी आप सही कर दो ना तो भी आप पास हो जाओ. बस उतना इंप्लीमेंट करना आना चाहिए, राइट? और आराम से हो जाएगा. When you see 5 questions difficult in a row, don't lose your nerves. There are easy questions are there. They will come. They will come. It is there somehow. कहीं ना कहीं आगे है, आ जाएगा. Have that gut feeling. Manifestation is a very important thing. Have that manifestation. मेरा होने ही वाला है, चाहे कुछ हो जाए. मेरे को 8 सब्जेक्ट अच्छे से आते हैं. I know 8 subjects very well. I'm going to pass. The remaining 10, 11 subjects, okay. But I'm not saying that you should do like this. But I'm telling to those, even those who are struggling with their all 19 subjects, let's make sure कि 8, 9 subjects we have been good, right? Okay. Let's come back to, this is all about the cardiology part. Now let's come to the second section, that is neurology. There are different types of tremors that we have. If, for example, when the patient's hand is going towards the object, in the initial phase, there is no tremor. When the patient goes near to the object and the tremor happens, शुरू में कोई tremor नहीं है, no tremor, no tremor. Near the goal, there is a tremor. It is called as intentional tremor because it feels that as if the patient is doing it intentionally. It is intentional tremor. It is seen in cerebellar lesion if there is a problem in the cerebellum. Resting tremor, if the hand is resting on the thigh and the tremor is there, resting tremor is seen in Parkinson. Essential tremors, you may have seen in your grandparents, their hand is always shaky like this. It is seen in old age. It is the essential tremor. Flapping tremor, it is seen in which condition? The option will be hypercarbia. It is seen in many conditions, but one of them, hypercarbia. Remember hypercarbia. If the carbon dioxide is more, you tell the patient to hold the hands like this, his hand is going to fall again and again, flapping tremor. This is also called as hysterexis. Yes, rightly said. One more question from cerebellum. If there is a cerebellar injury, the first point, we have 2 cerebellum. If the right cerebellum is gone, the symptom will come on the right side. So ipsilateral clinical feature. The clinical features are going to be ipsilateral. Second, to find out the cerebellar injury, we do some tests. And one of the important tests is Hill-Shin test. Remember the word Hill-Shin test is done for what? It is done for cerebellar injury. One more thing that we check is we tell the patient to do like this, one time like this, one opposite, and we tell him to do it rapidly. This is called as dysdiadochokinesia. If the patient is not able to do like this, it's called as the dysdiadochokinesia. So that is the cerebellar injury is there, there is going to be dysdiadochokinesia. Dysdiadochokinesia. If there is a problem in the basal ganglia, caudate nucleus, putamen, subthalamic nucleus, if there is a problem in these areas, if the caudate nucleus is gone, the patient is going to have the involuntary movement, but it is going to be fast. Rapid involuntary movement in the distal joint, it is called as chorea. C4 chorea, C4 caudate nucleus. If the rapid involuntary movement is happening, but it is, involuntary movement is happening in the distal joint, but it is slow, then this is called as athiotosis. Athiotosis, that is the injury of the putamen or the globus pallidus. If there is a sudden flinging movement, important question, sudden flinging movement, if the patient is flinging the arm like this, it is bellismus or hemibellismus, it is the subthalamic nucleus is damaged. Then here it is written, okay, the heel shin test, we tell the patient to drag the heel on the shin like this. This is called a heel shin test. It is done in the cerebellar lesion. This is the dysdiadochokinesia, rapid alternating movement the patient is not able to do. If the cerebellum is gone, the symptoms are going to be ipsilateral. The classical triad of symptom is going to be SIN, scanning speech, intentional tremor, and nystagmus. This is from the general part of the neurology. And one more point is, if there is a damage to the frontal lobe, the patient will be aggressive. If the patient is becoming aggressive, antisocial, he is having the problem in the frontal lobe. If there is damage to the parietal lobe, then we need to see that which parietal lobe is damaged, the dominant or non-dominant. If the dominant parietal lobe is damaged, then the patient is going to have the problem in the calculation, left-right problem, that is called as the Gertzmann-Straussler syndrome. If the dominant parietal lobe is gone, the patient will have the problem in the calculation, that is acalculia. There is going to be left-right problem, left-right defect, Gertzmann-Straussler syndrome. If the non-dominant parietal lobe is gone, there is going to be, the patient is going to neglect half of the world. There is going to be hemi-neglect. Hemi-neglect will be there. Then, if there is a damage to the temporal lobe, the patient will become Gajni. There is going to be short-term memory loss. The patient will not be able to remember the faces. He is not going to recognize the familiar face. That is called as prosopagnosia. Prosopagnosia. And because this word has came, Gertzmann-Straussler syndrome, I want to add two syndromes from the cardiology. If by any chance they say recurrent syncope, that the patient is becoming unconscious again and again, recurrent syncope is happening, then you need to see two things. If they are mentioning about the heart blocks, if the patient is having heart block in the ECG, and because of that the recurrent syncope episode is happening, heart block means damage to AV node. If the AV node is damaged and because of that the patient is having recurrent syncope episode, it is called as Stokes-Adams syndrome. If there is a recurrent syncope episode, and there is damage to SA node, SA node खराब हो रहा है, and because of that the patient is becoming unconscious again and again, this is called as sick sinus syndrome. So if you can remember all of them, very good. If not, remember one thing, recurrent syncope, if nothing is coming in your mind, take Stokes-Adams syndrome. Recurrent syncope with heart block, it is Stokes-Adams syndrome. Stokes-Adams syndrome. Then comes the management of stroke. We have the hemorrhagic stroke and the ischemic stroke. In the hemorrhagic stroke, we don't have to do much. We just have to control the blood pressure. Anyhow, control the blood pressure. And for that, we are going to give the injectable drugs such as the injection of labetalol. plus we'll give the anti-seizure medication. Anti-seizure medication. If there is a ischemic stroke, then we need to see that whether the patient has came within 4.5 hours of clinical feature or not. If the patient has came within 4.5 hours, then you will go for thrombolysis. Okay, let's add one more point here. If the patient has came within 4.5 hours, then you will check the blood pressure. The blood pressure is less than 185 by 110 or more than 185 by 110. If the patient is coming within 4.5 hours and the blood pressure is less than 185, then you can go for thrombolysis. You will give an injection that can dissolve the thrombus in the brain. And the drug that we are going to give is the TPA, that is generally injection of LDBs. That is 0.9 milligram per kilogram. If the blood pressure is more, now you tell me that if the blood pressure is more, the patient has came within 4.5 hours, but the blood pressure is more, what you will do? You will go for thrombolysis, yes or no? No. First, we'll control the blood pressure. First, control the blood pressure a little bit, and then thrombolysis. Because the patient has came within 4.5 hours, we can think of thrombolysis. But if the patient has come after 4.5 hours, the patient has not came within 4.5 hours, then you will check the blood pressure again. Now the cutoff for the blood pressure here, because you are not planning for thrombolysis, so you don't have to be aggressive against the blood pressure. If the blood pressure is less than 220 by 120, nothing to be done. Wait. Let's keep the blood pressure on the higher side. Just keep the blood pressure same. No need to decrease the blood pressure. No need to decrease. But if the blood pressure is more than 220, decrease the blood pressure. So the point is, in the ischemic stroke, whether to decrease the blood pressure or not. If you are planning for thrombolysis, the cutoff is 185 by 110. If it is more than that, decreasing. But if you are not planning for thrombolysis, the cutoff is higher. Then it is 220 by 120, right? Because we don't have to worry about that. This is all about the stroke management. It's a very important flow chart. It's a very important flow chart. Then comes the seizures. When it comes to seizure, I will tell you 5 buzzwords to remember to diagnose the different types of seizures. First, telling you the buzzwords, and then we'll go in little bit of detail about them. If they say that there is a 11 to 19-year-old boy, he loves to play video games, means there is decrease in the sleep, or they have used the word missed vaccinations, means he has not taken the vaccine of MMR. Then they are talking about myoclonic epilepsy, juvenile myoclonic epilepsy, juvenile myoclonic epilepsy. If they use the word personality change, personality changed means the patient's behavior has been changed. The family members are saying the behavior is changed. Plus, the patient is having automatism. Automatism such as cloth picking. Means the patient start doing like this. All of a sudden, he start doing like this. This is cloth picking. Then it is going to be focal impaired awareness seizure. The hallmark for the focal impaired awareness seizure is automatism. If they say perinatal hypoxia, means after the birth, the child has not cried for few minutes, perinatal hypoxia. and now the person is having the different types of seizures, then it is going towards Lennox-Gastaut syndrome. The last is if they use the word vacant stare in a child. Wherever the child is looking, the child is continuously looking there and there only for few seconds. Vacant stare is there. It is going towards absent seizures. So these are 4 or 5 important buzzwords to make the diagnosis of the different epilepsies. Here it is written the same. If they say the myoclonic epilepsy, which I have told already, the GME, there is 11 to 19-year-old boy. He loves to play the video games. There is a sleep deprivation is there. Late night video games is there. In the morning, the patient is having some jerky movements. And then one day it is followed by GTCS. It is GME. That can be associated with vaccine defaulters. Because vaccine, if the MMR is not taken, it leads to SSP. SSP can lead to GME. Here you can see the same buzzwords which I have written earlier. Late night video games, myoclonic epilepsy, missed vaccination, myoclonic epilepsy. If the hyponatremia is mentioned, sodium is less, GTCS. Child, whenever he is doing hyperventilation, he is having vacant stare, it is absent seizures. Juvenile age group, morning jerky movement, then GTCS, it is JME. Perinatal hypoxia, Lennox-Gastaut syndrome. And let me write down 2 important questions from EEG. Only 2 questions from EEG. If they write the word hips arrhythmia, it is seen in infantile spasm. 3 hertz spike in wave pattern. It is seen in absent seizure. So by chance, which is not happened till now, and I don't think it is going to happen, but by chance if it happens that a question comes and they have given you an image of EEG, which you are not able to read at your level, but if they have given you the image of EEG and they ask you diagnosis and you don't know the answer, take absent seizure. Because that is the only EEG which can be given to your exam. By chance, if they give you the EEG image and you don't know the answer, blindly take absent seizure. Here is the management of ischemic stroke, which I have told you. If the patient is coming within 4.5 hours, check the blood pressure. The cutoff is 185. If more than that, first control the BP. After 24 hours, if they're coming, check the blood pressure less than 120 or more than 120, and based on that, you decide. If the patient is coming 4.5 hours to 24 hours, plus minus, we can think of thrombectomy. Right? So this is, they ask that what is the next thing you will do. So you should be knowing this flow chart to make sure that you are not making the mistake in the management of stroke. Now coming to the meningitis part. In the meningitis, mainly they ask about the CSF analysis. Whenever there is a CSF, meningitis is there, how to make the diagnosis? The buzzword will be the patient will be having the fever, headache, neck stiffness. Fever, headache, neck stiffness, that is meningitis. But if I remove the fever, can you tell me what is the diagnosis? If there is no fever, but there is headache and neck stiffness. Headache and neck stiffness. Then what is the answer? The answer is subarachnoid hemorrhage. So the neck rigidity can be seen in subarachnoid hemorrhage, can be seen in meningitis. Fever, no fever is the difference. When it comes to meningitis, whenever there is a meningitis, there is going to be increase in the antibodies in the CSF. So there is going to be increase in the protein, whether it is bacterial, viral, tubercular, any one, the protein is going to be more. The main difference is going to be the sugar and sales. If it is a viral meningitis, the sugar is going to be normal. If it is a bacterial meningitis, there is going to be the neutrophils will be more. Neutrophils is also referred as PMN. So in the CSF, if you see a lot of neutrophils, that is indicating of bacterial. Whereas in the viral and tubercular, the lymphocytes are going to be more. So the main difference that is there is the PMN. If you see the word PMN, I hope that you already know that the PMN is the other name of neutrophils, right? So if the PMN or neutrophil is written, means it is a bacterial meningitis. If they give you this image, there is a web-like structure. This is called as the COV web. This is the COV web, and this is seen in tubercular meningitis. Seen in tubercular meningitis. This is the CSF manometer. When we how to check the opening pressure. This is basically how to check the opening pressure. For that, we have this CSF manometer. The next is the Alzheimer disease and the normal pressure hydrocephalus. There are two points I want to mention about these two. One is the normal pressure hydrocephalus. The normal pressure hydrocephalus, the classical triad is going to be ataxia, means imbalance. There is going to be dementia, means decrease in the higher mental function, and urinary incontinence. If you see this triad, the patient is not able to maintain his balance. There is decrease in the higher mental function, urinary incontinence. It's normal pressure hydrocephalus. You will do the non-contrast CT scan and you will see the big ventricles. The ventricles are very big in the brain. And the treatment, we will do a surgery where we are going to put the VP shunt. VP shunt is basically a tube which is connecting the ventricle to the peritoneum. So excess CSF is there. It is going to be coming in the peritoneum. So the CSF will not accumulate and will not create the problem. Normal pressure hydrocephalus. When it comes to Alzheimer disease, in that there are two defective proteins are accumulating in the brain. One is accumulating inside the neurons and one is accumulating outside the neurons. So here is the representation of the neurons. The protein which is accumulating outside the neurons, this is amyloid beta 42, which is also referred as neuritic plaque. The protein which is accumulating inside the neuron, this is going to be tau protein. And when the tau protein accumulates, this is called as the neurofibrillary tangles. So the question that comes is, which protein is associated with the severity of Alzheimer's disease? The severity of Alzheimer's disease is directly proportional to tau protein. Severity of Alzheimer's disease is directly proportional to tau protein, or we can say NFT. The more the NFT, the more the severe Alzheimer's disease. Alzheimer's disease is also associated with a protein called as ApoE4, which is found on chromosome number 19. Then in the Alzheimer's disease, the most common site or the most common lobe to be damaged, it is temporal lobe. There is going to be temporal damage. In the temporal also, there is going to be particularly hippocampus that is going to be damaged. If they ask that, where is the least damage? The least damage is going to be occipital lobe. The highest damage is in the temporal lobe, the least damage is in the occipital lobe. In the treatment of Alzheimer's disease, we are going to give acetylcholine esterase inhibitor so that acetylcholine will increase, such as the donepezil, rivastigmine, galantamine. Acetylcholine will increase. The next we are discussing is the Parkinsonism. What is the meaning of Parkinsonism? Is actually Parkinsonism is a combination of two symptoms. If in any patient you see bradykinesia, means there is a slowness in the movement. Means you tell the patient to grab the water bottle and his hand is moving very slowly, bradykinesia. Plus rigidity. Rigidity means increase in the tone of the muscle. The muscles are stiff. If you see this combination, bradykinesia with rigidity, it is Parkinsonism. Then you have to see that this Parkinsonism features are found in which part of the body. If the Parkinsonism-like features are there in the limbs, if the features are there in the limbs, then this is called as typical Parkinsonism. And if these features are there in the axis, if the neck is becoming stiff, if the vertebrae are becoming rigid, the bradykinesia is in the neck, then it is atypical. Atypical. The typical Parkinsonism features are seen in Parkinson disease, whereas atypical Parkinsonism features are seen in multiple disease such as MSA, PSP. I'm just writing two. How to make the diagnosis of MSA and PSP? Let's clear that first, and then we'll go to the Parkinson disease in detail. If you see that in any patient, they are saying that the patient is having the problem in the neck, vertebrae, they are becoming stiff, the bradykinesia is there. Either it is MSA or PSP. How you will differentiate is in the MSA, they will use the word orthostatic hypotension. Orthostatic hypotension, or they will use the word cerebellar symptoms, cerebellar clinical feature. So with the atypical Parkinsonism, if there is orthostatic hypotension, it is MSA, multi-system atrophy. If they say atypical Parkinsonism plus vertical gaze paralysis, then it is going to be PSA, progressive supranuclear palsy, PSP, sorry, progressive supranuclear palsy. So this is how we find out whether it is MSA or PSP. Now coming to the Parkinson disease. When it comes to Parkinson disease, it is due to a wrong protein called as alpha-synuclein. When the alpha-synuclein accumulates, it's called as Levy body. That is going to accumulate in the substantia nigra. And because of that, there is going to be decrease in the dopamine. It's called as the Parkinson disease. If they ask that what is the earliest and the most common motor feature, it is going to be resting tremor. The earliest and the most common motor feature, resting tremor. If they ask that what are the other signs are there, if you tap on the glabella, the eye will blink every time. It's called as glabellar tap sign. Also called as Meyerson sign. The handwriting of the patient is going to be small. That is called as the micrographia. Micrographia. So this is all about the Parkinson disease. The next is the myasthenia gravis. When it comes to the, just a second. The next is the myasthenia gravis. When it comes to myasthenia gravis, there are two things to be remembered for myasthenia gravis. It's a wrong antibody which is damaging the neuromuscular junction. There are three wrong antibodies which can be associated. It can be acetylcholine receptor antibody, MuSK antibody, LRP4, but most commonly is anti-acetylcholine receptor antibody, and that is going to attack the acetylcholine receptors. Now, because of that, what will happen? See, normally the signal from the brain is going to your muscles via the nerves, and the signal travels in the form of action potential. So when the nerve having the signal in the form of action potential, it is coming. It has came to the last part of the nerve. And here is the muscle. Now the signal is supposed to go in the muscle. Normally, this action potential is going to open the calcium channels. There are two types of calcium channel, slow and fast. From both of them, the calcium comes. And this calcium is going to push the acetylcholine vesicles. This acetylcholine vesicles will come near to the snare protein. The snare protein is going to cut the vesicles. A lot of acetylcholine will come here. It is going to attach to the acetylcholine receptors and the muscle will contract. But because these antibodies has blocked these receptors, so the muscle contraction will happen less, and this is called as myasthenia gravis. It is associated with thymus pathologies. Those who are having thymic hyperplasia or thymoma, they develop myasthenia gravis. The main characteristic feature is in these patients, in the morning, they don't have much problem. In the evening, they have the problem. So if they write this thing that in the morning, there is no muscle weakness, but in the evening, the muscle weakness is visible. The muscle weakness is visible in the evening, then it is going towards myasthenia gravis. And mainly this muscle weakness will be visible in the eyelids. There is going to be ptosis will happen, and this is going to be unequal ptosis. In one eye, the ptosis will be more. In another eye, the ptosis will be less. So if we see the unequal ptosis, then it is going towards the myasthenia gravis. The most sensitive test, it is the single fiber EMG. single fiber electromyography. The most specific test, it is the anti-acetylcholine receptor antibody. We'll try to find the antibody. Anti-acetylcholine receptor antibody. Then when it comes to the management, we are going to give the pyridostigmine. We'll plan for thymectomy. But they ask one question that before thymectomy, which test should be done? We'll plan for thymectomy, but before surgery, pulmonary function test is done. So this is all about the myasthenia gravis. There is one more test. Can you tell me which we do in the OPD of myasthenia gravis? We tell the patient to put something on the eye, and after that, the ptosis is going to decrease. We can do that test also, and that is going to be what? That is the eye spec test. Eye spec test can be done. There was one exam where there were 3 questions has came from myasthenia gravis alone. 3 questions. So let me give you the 3 buzzwords to be remembered. If there is morning, evening, if such combination is given, in the morning, there is no muscle weakness. In the evening, muscle weakness is there. It is myasthenia gravis. But if they are opposite, in the morning, there is muscle weakness. In the evening, there is no muscle weakness. Then this is Lambert-Eaton syndrome. Lambert-Eaton syndrome. If they say in the morning there is joint stiffness, but evening decrease in the joint stiffness, the joints are relatively better in the evening, it is rheumatoid arthritis. But if I do opposite, in the morning there is no joint pain, and evening joint pain is there, mainly happening in the evening, it is osteoarthritis. So this is the combination of morning, evening, morning, evening. Lambert-Eaton syndrome, yes, Lambert-Eaton syndrome is associated with the small cell lung cancer. So I want you to remember one word about lung cancer is, if they say a patient of lung cancer is coming to you and he is having hypercalcemia, the moment that combination is there, lung cancer with hypercalcemia, the answer is squamous cell cancer. Why in the squamous cell cancer we have the hypercalcemia is because the squamous cell cancer is going to increase the parathyroid hormone related peptide, PTHRP, not PTH, PTHRP, and that is going to increase the calcium. So if they say lung cancer with hypercalcemia, the answer is squamous cell cancer. Squamous cell cancer. Then comes the Guillain-Barré syndrome, super important topic. We all know that how the patient is going to present to us, right? They will say about one trigger that the patient has developed some GI infection, some surgery, some respiratory infection. And after that, there was wrong antibodies were made. And these wrong antibodies were attacking the myelin sheath of the neurons. So basically, it's an acute demyelination that is going to happen. And it's an autoimmune acute demyelination. The wrong antibodies will damage the peripheral nerves. Initially, the demyelination will happen near to the ankle joint, then the knee joint, and slowly, the paralysis is going to ascend up. This is the ascending motor paralysis. In this Guillain-Barré syndrome, there is no involvement of the brain. So the higher mental function is absolutely normal. The higher mental function is absolutely normal. When you check the deep tendon reflux, the first reflux to be lost is going to be the ankle joint, then is the knee joint, then is the further reflux will be lost. When this question comes, actually, listen to these words carefully. This question will be coming like this. They will say about the diagnosis. They will say there is a patient, he developed some infection. After that, he developed paralysis. The paralysis started from the ankle joint, then it was ascending up. And what is the diagnosis? When you are reading this question, you are very happy. because you are knowing that it's GBS. But when you look at the option, there is no option saying GBS. Actually, the GBS is the acute demyelination happening in the multiple nerves. So we have one more name for the Guillain-Barré syndrome. It is acute inflammatory demyelinating polyneuropathy, AIDP. So instead of GBS, they are going to use the word AIDP. This they have did in your exam. Instead of the GBS word, they will use acute inflammatory demyelinating polyneuropathy. When it comes to the diagnostic criteria, we are going to use the Brighton's criteria. If we do the nerve conduction velocity test, the NCV test, because there is a demyelination, so the velocity is going to be less. There is going to be increase in the latency. We have to remove these bad antibodies immediately because they are leading to demyelination. There are two methods to remove the bad antibodies. What you can do is you can give the good antibodies that can attack the bad antibodies and can destroy it. This is one thing. Or secondly, you can give you can take the plasma out, you can filter the plasma, you can remove the bad antibodies, and you can give the plasma back, that is plasmapheresis. So IVIG or plasmapheresis, any one can be given. This is all about the Guillain-Barré syndrome. But if the same thing is happening in the reverse direction, instead of ascending motor paralysis, if there is descending motor paralysis, it is Miller-Fisher syndrome. Descending motor paralysis, it is going to be the Miller-Fisher syndrome. Now coming to the upper motor neuron and the lower motor neuron lesion, how to differentiate UMN and LMN. So for that, we need to understand what is the meaning of motor neuron is. For example, we know that the right brain is controlling the left body. So for example, if I want to have a movement in my left bicep, the signal should come from my right brain. In the right brain, we have the motor area. And from there, the motor neurons are coming and they are going to their individual muscles. So there is one neuron which is controlling my bicep. There is one neuron which is controlling my tricep. So that neuron from here, for example, here is the main motor area on the right side of my brain. From here, the neuron is starting. This purple color, the blue color one. This neuron is coming down. It is coming down in the brain stem part, in the lower part of medulla oblongata. It is going to cross over. Then it is going to go in the spinal cord, and then it is going to stimulate one specific anterior horn cell. From the anterior horn cell, now the signal will go to the peripheral nerve, and the peripheral nerve will take the signal to the muscle. So actually, this is how my muscle is getting contracted. For every muscle, I have a specific neuron in my brain. From the brain to the spinal cord, this particular neuron, which you can see in the blue color, this is cortico-spinal tract, cortico-spinal. Then we have the anterior cell, that is the second neuron. Then the third one that you can see in the green color is the peripheral nerve. So actually we have three motor neurons, the corticospinal tract, the anterior cell, and the peripheral nerve. We can divide them into two groups. The corticospinal tract is referred as upper motor neuron, and peripheral nerve and anterior cell is referred as lower motor neuron. If by chance, if there is a problem in any of these three, the muscle will not contract. The paralysis will happen. So whenever a patient is presenting with motor paralysis, we want to find where is the problem, in the corticospinal tract or the anterior cell peripheral nerve. If the problem is in the upper motor neuron, it's called as upper motor neuron lesion. If there's a problem in the lower motor neurons, it's called as lower motor neuron lesion. So we have two types of paralysis, upper and lower. If there is a upper motor neuron paralysis, the paralysis will be there, muscle tone will be high. In the UMN, the spasticity will be there, the reflex will be brisk. The mnemonic is USB. So the next time you see a patient, he is having a paralysis in the muscle. You want to find where is the problem, upper or lower. What is upper? Upper is corticospinal tract. Lower is anterior cell and peripheral nerve. You want to find out where is the problem? Check the muscle tone. If the muscle tone is more, the reflex are brisk, it is upper motor neuron problem, means corticospinal problem. If the muscle tone is less, the muscles are flaccid, the reflex are absent, it's lower motor neuron problem. So the mnemonic is USB. B stands for brisk reflex. B stands for Babinski sign. We are going to check the plantar reflex. We are going to rub the sharp object on the sole like this. If all the finger goes in the flexion, it's a plantar reflex normal flexion. But if the grade 2 is going in extension, not in the flexion, then it's an extensor plantar, and that is seen in the UMN lesion. That it will be referred as the Babinski sign, right? In the upper motor neuron, we don't have the fasciculation. Fasciculation is the twitching of the muscles that is seen in lower muscle wasting. Fasciculation, they are seen in lower motor neuron type of paralysis. Now, can you tell me some more answers? Can you tell me some more answers that key? I will tell you the name of the disease. You tell me that it will come under which type of paralysis. Guillain-Barré syndrome will come under which type of paralysis? Upper motor neuron type of paralysis or lower motor neuron? Because in Guillain-Barré, we have the paralysis, it's UMN or LMN. In Guillain-Barré, we have the demyelination of what? Demyelination of the peripheral nerves. And peripheral nerves come under what? Lower motor neuron. So Guillain-Barré is the element type of paralysis. In the same way, if I ask you, let's say polio. Polio can also lead to paralysis. Polio comes under which category? Because polio damages the anterior horn cell, and anterior horn cell is the anterior lower motor neuron. Myasthenia gravis can lead to muscle weakness. So myasthenia gravis comes under which category? Upper or lower? Because in myasthenia gravis, there is a problem in the neuromuscular junction. And neuromuscular junction is going to come in the lower motor neurons, right? So this is how it is divided, upper and lower motor neurons. Now coming to the facial palsy, I want you to remember 4 words about facial paralysis, and the facial palsy is done. First, you may have heard about the element type, UMN type. If the entire half of the face is paralyzed, it is element type. If just the lower part is paralyzed, it is UMN type. So this is the element type and this is UMN type. So depending where is the paralysis. The second question, and that is more important, they ask where is the lesion. Now everyone listen here. If a person is having the paralysis in the entire half of the face, means it's element type. For example, in this person, this is the right side of the face, this is the left side of the face. This patient is having the entire left side of the face is paralyzed, means element type of paralysis on the left side. They will ask where is the problem you will see on the MRI? Where is the lesion? Can you tell me that in element type of paralysis, when we'll do the MRI, where we'll find the problem on the left side of the brain or the right side, where we are going to find? In the element type, the problem is going to happen on the same side. You will be able to see the problem on the same side. Whereas in the UMN, you will see the lesion on the opposite side. So here it is written. This is very, very important. In the element, the lesion is seen on the same side, whereas in the UMN, the lesion is seen on the opposite side. So there are 4 words I want you to remember. If an entire face is involved, it is element type. And in the element type, the problem will be seen on the MRI on the same side. And if it is UMN type, just lower half is paralyzed. It is UMN type, the problem will be seen in the other part, means the opposite side on the brain MRI, right? This is how to be remembered by facial palsy. And this is all about the neurology part. But I want to add 3 points here. One is about the lateral medullary syndrome. Also called as pica syndrome. What they ask is, what is not a clinical feature? What is not a clinical feature of lateral medullary syndrome? The answer is the paralysis. Hemiparesis is not a feature. There are many features are there. Hemiparesis means paralysis in the half of the body is not a feature. One important clinical feature is crossed hemianesthesia. Crossed hemianesthesia, yes, it's a feature. So lateral medullary syndrome, what is not a feature? Hemiparesis. Paralysis is not a feature. Loss of sensation, that is anesthesia. Anesthesia is a feature. Then, when it comes to the Weber syndrome, if a patient presents with the third cranial nerve paralysis, ophthalmoplegia, there is a paralysis of the third cranial nerve, plus the patient is having hemiparesis, half of the body is paralyzed, plus Parkinson-like features. If we see this combination, it's a Weber syndrome. Weber syndrome. That comes to the gastroenterology, gastroenterology. The first is the bilirubin metabolism. So now we have covered 2 major giants of medicine. The 2 major giants is the cardio and neuro. Now there are smaller systems are there, gastro, rheumat, pulmo, endo, right? Among them, we can say respi is relatively bigger. Baki to it's not very big. And I will keep the things very to the point, straightforward, so that if this word will come, you will be able to answer directly the main buzzword, right? So when it comes to the bilirubin metabolism, uh, just 1 minute. When the RBC breakdown happens in the spleen, the hemoglobin comes out. The hemoglobin further breaks in the heme and globin. The heme further breakdowns in the biliverdin. Then it further breaks down in bilirubin. Now we generate a lot of bilirubin in the spleen. The spleen is confused what to do with this bilirubin. It's a waste product, but the problem is it is water insoluble. So the spleen is not able to throw it out. The spleen will request to the liver that please make it water soluble and throw it out. So this bilirubin will be transferred to the liver with the help of albumin. And in the liver, the bilirubin on the water insoluble bilirubin, we are going to attach some molecules. We will conjugate some molecule so that it becomes water soluble. So this water soluble bilirubin, which is made in the liver, this is referred as conjugated bilirubin because it was made by conjugation. And the name of the enzyme which is going to help in the conjugation is UDP glucouronyl transferase. Then this conjugated bilirubin will come out of the liver with the help of MRP2 and we will throw it out. This conjugated bilirubin in the intestine, it will convert into urobilinogen, then it converts into stercobilinogen, and then it comes in the stool. So this is how we majority of the part of the bilirubin we throw it out. Some urobilinogen is absorbed back and it goes to the kidney, and these urobilinogen can come in the urine also. That is why the urine is light yellow. But the problem is some molecules of conjugated bilirubin is also absorbed back, which we don't want actually. We don't want conjugated bilirubin. We want to throw it out, but it gets absorbed. It comes in the portal vein and it is going to knock at the liver that let me please come inside. And liver does not refuse to anyone. So liver will make a special entry channel B1 and B3, and by which the conjugated bilirubin will come in. But the moment the conjugated bilirubin will come in, this conjugated bilirubin will be again mixed with this bilirubin and again it will be thrown out. So this is how we regularly removing the bilirubin from our body. But by any chance, if the bilirubin is not removed, it is going to increase in the body, and that is called as hyperbilirubinemia. For example, if no need to write this, if there is a problem in this particular enzyme, if this enzyme is not working, then the conjugated bilirubin is going to increase. In the same way, if the MRP channels are not working, then the conjugated bilirubin is going to increase. In the same way, if the ATP channels are not working, the conjugated bilirubin is going to increase. So in some disease, the conjugated bilirubin is going to increase. In some disease, unconjugated bilirubin is going to increase. So we have the conjugated hyperbilirubinemia, we have the unconjugated hyperbilirubinemia. How to remember them? It's with a simple mnemonic. It is double roti. How to make double roti with the help of conjugation? You take one roti, you take one more roti, you conjugate, you make double roti. So in double roti means Dublin-Johnson and Rotard syndrome. There is going to be increase in conjugated bilirubin. Then you will say, sir, how to differentiate? In both of them, the conjugated bilirubin is high. Dublin-Johnson is going to be very severe compared to Rotard. That is one thing. In Dublin-Johnson, the main buzzword is black liver. The moment you see the word black liver, it is Dublin-Johnson. Why? Because in Dublin-Johnson, the MRP channels are not working. If the MRP will not work, the conjugated bilirubin can't come out. And that is going to change the color of the liver. So in Dublin-Johnson, it is due to defect of MRP, and that is going to lead to black color. Now coming to the other two, that is the Gilbert and Crigler-Najjar. In the Gilbert and Crigler-Najjar, there is going to be increase in the unconjugated bilirubin. Then again, you will say that how to differentiate. Gilbert is going to be mild, and it is going to be intermittent, on and off. Come and go, come and go. So if they say that is a 10-year-old boy, 15-year-old boy is coming to you on and off, jaundice is there, it is Gilbert. Crigler-Najjar is going to be more severe. It is going to present early in the life. Now, can you tell me that in hemolytic anemia, which type of bilirubin is going to increase? In hemolytic anemia, which type of bilirubin will increase? In hemolytic anemia, which type of bilirubin will increase? Conjugated or unconjugated? Hemolysis will happen, and hemolysis happens in the spleen. If you break a lot of hemoglobin, RBCs, a lot of hemoglobin will come, a lot of hemoglobin will make a lot of bilirubin, and that is going to be which type of bilirubin? The water insoluble, means unconjugated. So in hemolytic anemia, there's going to be unconjugated bilirubin will increase. Then how will differentiate? In hemolytic anemia, the hemoglobin will be less in the patient. That is one hint. Plus, there is going to be increase in the LDH. Which LDH will be more in the blood? LDH1. Can you tell me that if there is a stone in the CBD, if there is a CBD stone, common bile duct stone is there, which bilirubin will increase? CBD stone. If there is a stone in this area, if there is a stone in the common bile duct, then which bilirubin is going to increase? Yes, it is going to be conjugated bilirubin will increase. Then they will ask that how you differentiate from double roti. In the CBD stone, the conjugated bilirubin will increase, plus there is going to be increase in alkaline phosphatase, ALP, because there is obstruction. Whenever there is an obstruction in the biliary ducts, ALP is going to increase. Plus, there is going to be clay color stool. White color stool will be there. Clay color stool. So this is how you differentiate Dublin-Johnson, Gilbert, Krigler-Najjar, hemolytic anemias, and CBD stones. In all of them, the bilirubin is increasing, either conjugated, unconjugated. You should be knowing that because they don't ask. See, there are two types of question. One, all of the following will have increase in the unconjugated, or all the following have increase in conjugated. That is one question. But nowadays they ask that what is the diagnosis? And they give you some hint, right? Decrease in hemoglobin, increase in LDH with increase in the unconjugated bilirubin, it's hemolytic anemia. Clay color stool with increased conjugated bilirubin, CBD stone, right? So this is how to be remembered. LDH1. Now comes very important part. For the next 3 minutes, 3 to 5 minutes, definitely we'll be solving one question. So I want everyone to be very attentive. Look at here. The serology of hepatitis B. Serology of it. And I will give you a very simple trick to solve the question. In any question of hepatitis B, first see that the which type of core antibody is given, IgM or IgG. If IgM antibody is given, then it is an acute hepatitis B. If IgG is given, then there are four possibilities: chronic, carrier, recover, remote recover. Then you will check the surface antigen. If the surface antigen is present, you tell me that if a person is recovered, will you find any antigen in his blood? If a person is recovered or remotely recovered, will you find any antigen? No. So, if the IgG antibody is there, but there is no antigen, the person is recovered or remote recovered. But if the antigen is there, it can be chronic or can be carrier, symptomatic or asymptomatic. Then how to differentiate recover from remote recover? You will check the surface antibodies because the surface antibody disappear after 10 years. So if because whenever we have the hepatitis B infection, there are three antigens, there are three antibodies. So if a person is recovered from hepatitis B, in his body, there will be three antibodies. In his blood, there will be three antibodies. But after 10 years, the surface antibodies will disappear. Only two antibodies will be left. So if a person has been recovered, then you will check the surface antibodies there or not. If it is there, it is recovered. If it is not there, it's remotely recovered because after 10 years, surface antibody disappears. One more question. If only surface antibody is there, only surface antibody, that is seen in which condition? It is seen in vaccinated persons because the vaccine is made up of the surface antibodies, surface antigens. So let's use this because it's very important. So let's solve three questions. First question. Use the algorithm. You open the flow chart. You open the flow chart. No need to open the question in your workbook. Look at here. If they say there are some types of antibodies are there in the blood of the patient, total antibodies positive. But when we check the IgM type of antibody, it was negative. If the IgM is not there, but antibodies are there, then which type of antibodies are there? IgG. Automatically, it indicates that IgG is there. IgG is there means there are four options: chronic, carrier, recover, remote recover. Then what you will check? Surface antigen. Can you tell me if the surface antigen is present? What are the two possibilities? Recover, remote recover, or chronic carrier? If the antigen is still present, it's antibody is there, G type, but the antigen is still there, then it is going towards what? Chronic. And because SGOT, SGPT is increased, so it's a chronic hepatitis B. It's a symptomatic stage, chronic hepatitis B. Let's come to this thing. The total antibody is present, but IgG is present. Total is present and IgG is present means IgG is present actually. IgG is present means there are 4 possibilities: chronic, carrier, recover, remote recover. Then I saw surface antigen is not there. No surface antigen means it is recovered. Then I have to see recovered or remote recovered. I want to find surface antibodies because after 10 years, surface antibody disappears and the surface antibodies was not there. Then the answer is going to be what? Remote recover. Remote recover. Can you tell me what is the answer for this question? What is the answer for this question? Total antibody is present, but the G antibody is negative. If the G is negative, then automatically which antibody is there? IgM. If the G is not there, but total is there, means IgM is there. And if the IgM is there, then automatically what is the answer? It is acute hepatitis B. In the acute hepatitis B, how it is possible that you are not able to see the antigen? If there is a acute hepatitis B is going on, why you are not able to see the antigen? Because in the acute hepatitis B, there is one period comes between 24 to 28 weeks where you can't see the surface antigen, where you can't see the surface antibody, and that is called as which period? Window period. So this patient is having acute hepatitis B that we have figured out with the help of IgM antibodies. But why surface antigen is not there in acute? It is because of window period. So have you understood this? Let me give you again a small summary. Now you give me this answer. Even if you don't write in the chat box, it's completely fine. But tell the answers. Tell the answers. Whenever the serology question will come, what is the first thing you will try to see is the core antibody. That which type of core antibody is there, IgM or IgG. If the IgM is there, then automatically what is the answer? Acute hepatitis B. If the IgG is there, there are 4 possibilities. What are the 4 possibilities? Chronic, carrier, recover, remote recover. These are the 4 possibilities. Then what you will check? You will check the surface antigen. If the surface antigen is present, means still the antigen is present, either it is chronic or it is carrier, symptomatic or asymptomatic. Based on that, you will figure out. If the surface antigen is not there, means either it is recover or remote recover, then you will see the surface antibody. Because the surface antibody disappears after 10 years. If the surface antibody is there, it is recover. And if the surface antibody is not there, it is remote recover. Is this point is clear? Just remember this much. Your serology question will never go wrong. Never go wrong. Just one thing is not there in this flow chart is the vaccinated person. In the vaccinated person, we just see one antibody, that is the surface antibody, because the vaccine is made up of surface antigens, smaller part of surface antigen. So let's add one that statement, that is in the vaccinated person, we are going to have only and only surface antibody. Surface antibody, that's all. Done. Hepatitis B serology done. Very good. Let's some facts, few facts. The most common acute viral hepatitis. Acute viral hepatitis is generally A or E. In children, it is A. In adults, it is E. In pregnancy also, it is E. So acute is either A or E. But if they say overall, acute and chronic, overall, the most common viral hepatitis is B. And mostly the hepatitis B is going to transmit vertically from mother to child. Which is the most common chronic hepatitis? The chronic is also going to be B. What is the most common viral cause of hepatocellular cancer? What is the viral cause? Hepatitis B. What is the most common carrier state of hepatitis? Hepatitis B. Can you tell me what is the most common cause of viral cause of cirrhosis? Viral cause of cirrhosis. C for cirrhosis, C for hepatitis C. There is only one thing where the answer is hepatitis C, that is cirrhosis. Remaining everywhere the answer is B. Everywhere the answer is B. This is how we have to remember. Most common viral hepatitis, most common viral cause of cancer, most common chronic hepatitis, most common carrier, most common this, that, B. For cirrhosis, answer is C. Done? Now coming to autoimmune hepatitis. This is a new topic and it's important. So I will make sure that you will remember here itself. Look at here. Look at to me. See, no need to write anything. Nothing is there to be written. Autoimmune hepatitis means there is a wrong antibody which is destroying the liver, right? So if a person is having autoantibodies, tell me that if a person is having autoimmune hepatitis in his blood, the amount of the antibodies that you are going to see will be more or less the total antibodies. If a person is having some kind of autoimmune disease in his blood, you will see more antibodies or less antibodies. More antibodies, right? So if I want to make a diagnosis of autoimmune hepatitis. In the blood, there should be more antibodies. The total antibodies in the blood should be more. Second, these antibodies will be attacking the liver, and in the liver, you will be able to see the plasma cells because of that. So, if I want to make a diagnosis of autoimmune hepatitis in the biopsy, I should be able to see the plasma cells. So, two diagnostic criteria you understood in the autoimmune hepatitis. In the blood, there should be more antibodies. Second, in the liver, you should be able to see the plasma cell. Plus, you have to rule out the viral hepatitis. If you want to say it's autoimmune, you have to rule out the viral hepatitis. Plus, the fourth thing, you have to find some wrong antibody, such as ANA, SMA, LKM, SLA, any such wrong antibody should be there. So, what is the diagnostic criteria? This is called as the simplified scoring system. What is simplified scoring system? Let's revise and we'll remember here itself. Four things. If a person is having autoimmune hepatitis, in his blood there should be more antibodies. In the liver, you should be able to see plasma cell. Third, you should rule out viral hepatitis. Fourth, you should be able to find the wrong antibodies. If you are able to do all the things, it's autoimmune hepatitis. If you can't remember this, then remember that there are two types of autoimmune hepatitis, type 1 and type 2. Type 1 is because of which wrong antibody is damaging the liver. Is it ANA? Is it ANA, SMA, or SLA? If these antibodies are damaging the liver, it is type 1. If the LKM antibodies are damaging the liver, it is type 2. So if you can't remember any statement, remember that if the LKM one word is written, it is type 2 autoimmune hepatitis. If LKM one word is written, it is type 2 autoimmune hepatitis. That's all. This is all about the autoimmune hepatitis. Now coming to the alcoholic liver disease and the non-alcoholic liver disease. Look at here. Right now, your liver is like this. Normal liver is like this. When we consume the alcohol, the first thing that is going to happen to our liver is there is going to be accumulation of the fat. And when the fat accumulation happens, that is called as the fatty liver, also called as steatosis, alcoholic fatty liver. But at this point, the SGOT, SGPT is normal. But if a person consumes more and more alcohol, then the SGOT, SGPT will start increasing, particularly SGOT, because in alcoholic patient, OT increases more. And if in SGOT, SGPT increases, now this is not called as steatosis, now this is called as steatohepatitis. There is inflammation is going on. This is alcoholic fatty hepatitis. If the patient does not take care here, either the person will convert into cirrhosis or will convert into cancer. So this is the stages of the alcoholic liver disease. The first stage is the fatty liver. Second, there is going to be fatty hepatitis. Then there is going to be cirrhosis, or there can be cancer. Till this point, it is reversible. Fatty liver, fatty hepatitis, reversible. But cirrhosis, cancer, irreversible. The same thing can happen without alcohol also, because you have seen your relatives who are non-alcoholic, but when they did the sonography, their liver is showing fatty liver. So the same thing can happen without liver, without alcohol also. If without alcohol that happens, that is called as the non-alcoholic fatty liver disease. Do you remember? If the same thing happens without alcohol, so non-alcoholic fatty liver disease, NAFLD, then non-alcoholic steatohepatitis, NASH, and then there is going to be cirrhosis. So alcoholic liver disease, non-alcoholic liver disease, ultimate things are same. In both of them, there is going to be fatty liver. In both of them, there is going to be steatohepatitis. In both of them, there is going to be cirrhosis. If it is because of alcohol, it's alcoholic. If it is not alcohol, it's non-alcoholic. The main question is, see, fatty liver wala patient to kabhi aapke paas aayega hi nahi. Alcoholic fatty liver will not come because he's not having symptoms. He is asymptomatic. But alcoholic hepatitis will definitely come to you, and they ask this question that in alcoholic hepatitis, whether you will give steroids or not. Very important question. You will calculate a score called as DF, discrimination factor. If the discrimination factor is coming more than 32, if the discrimination score is coming more than 32, you will give steroids. If it is coming less, no steroid. If you don't want to calculate discrimination factor, you can calculate the MELD score. So if the discrimination score is more or the MELD score is more, go for steroid. If not, no steroid. This is what is to remember. Alcoholic hepatitis, whether to give the steroid or not to give steroid, it is calculated by DF or MELD score. If the DF or MELD is more, and what is the component of MELD? The component of MELD is CBI. CBI. Or whenever there is a combination of three, potential all except quotient, creatinine, bilirubin, INR. So MELD score more than 21 or DF more than 32, go for steroid. If not, no need. The moment the person develops cirrhosis, then we can't do anything. Then the only thing that you can do is the liver transplant. But remember, they ask that what is the contraindication for liver transplant? Liver is a very precious organ. We can't put the liver in a person which is not going to survive anyhow. So if a person is having AIDS, metastasis of the cancer, severe sepsis, severe cardiac disease, we don't do the liver transplant because anyhow he is going to die. So we are not going to vest the liver in that person, right? So this is all about the alcoholic hepatitis, right? Now the next thing is the portal hypertension. Normally look at the portal vein. Look at the portal vein. The portal vein is taking the blood to the liver, and then the blood is coming in the hepatic vein like this. If a person is having cirrhosis, then the blood will start accumulating in the portal vein, and the portal vein pressure is going to increase. But because the blood is not able to go in the portal liver, so less blood will be in the liver. I would say that the less blood will reach to the hepatic vein, so the hepatic vein pressure will decrease. So what is portal hypertension? If the portal vein pressure is more than 10, this is portal hypertension. Or you can check the hepatic portal vein pressure gradient. What is portal vein pressure gradient? Is portal vein pressure minus hepatic vein pressure. Portal vein pressure is more, hepatic vein pressure is less. If the difference is more than 5, this is also portal hypertension. So there are two definitions for portal hypertension. Portal pressure is more than 10, or the difference between the portal and hepatic vein is more than 10, more than 5. That is also the portal hypertension, right? Now, because of that, what is going to happen? The moment the person has developed portal hypertension, the blood is not able to go in the liver, so the blood is going to accumulate in the portal vein. And now, because of that, there will be back pressure. Because of the back pressure, there's going to be esophageal varices, there's going to be splenomegaly, there's going to be caput medusae like this, because the umbilical vessels are going to distend it, the blood is not able to go forward, the blood is not able to go. So there's going to be splenomegaly, there's going to be varices, there's going to be hemorrhoids. These are the features of the portal hypertension. Here again, the same thing is written, hepatic vein pressure gradient. The portal vein pressure is more, the hepatic vein is less. If it is more than 5, it is portal hypertension. If it is more than 10, it is clinically significant portal hypertension. If it is more than 12, the patient must have developed esophageal varices. So they ask this question that when to say it's a significant, clinically significant portal hypertension. If the hepatic vein pressure gradient, is more than 10. More than 5 is portal hypertension, but more than 10 is going to be clinically significant. What is this tube is? This is the Blackmore-Sengstrom tube that can be used for the esophageal varices. But what they ask is, when we put this tube, there are two questions. One question, they give you this image, they ask you, what is the name of this? This is the Blackmore-Sengstrom tube. We put this and we inflate the balloon. There are two balloons. And this balloon, how much air will be there in the balloon which is there in the abdomen? It is around 300 ml of air will be there. 300 ml of air. And when you inflate the balloon, you want to keep the pressure below less than 40 millimeter of mercury, because if the pressure is more, it will lead to pressure necrosis of the esophagus, which we don't want. So they ask that when you inflate the balloon, you want to keep the pressure of the balloon less than what? Less than 40. How much air should be there in the balloon? 300 ml. This is a Blackmore-Sengstrom tube. Now, one difficult question, if you can remember, it's difficult, but if you can, look at here. The portal vein, the blood is going in the liver like this. In the liver, we have the sinusoids. So the blood will go in this area. This is the pre-sinusoidal space. Then the blood will go in the sinusoids. Then the blood will come in the post-sinusoids. And then the blood will come in the hepatic vein. And then it is going to go forward. By any chance, if there is obstruction in this entire route, the portal vein pressure will increase. For example, if there is some obstruction here in the prehepatic area, that is called as prehepatic portal hypertension, that is seen in portal vein thrombosis. If there is a problem in the pre-sinusoidal area, such as schistosomiasis, there is a parasite which can stuck here, and because of that, the back pressure will increase, and that is called as the pre-sinusoidal portal hypertension. We can have the sinusoidal portal hypertension if there is a problem in the sinus area, such as cirrhosis. If the problem is in the post-sinusoidal area, that is veno-occlusive disease. If the problem is there in the hepatic vein, such as the Budd-Chiari syndrome, that is a post-hepatic portal hypertension. So the portal hypertension is divided into three categories depending where is the problem: prehepatic, prehepatic, hepatic, and post-hepatic. And the hepatic is further divided into three. Hepatic is further divided into three: sinusoidal, pre-sinusoidal, and post-sinusoidal, depending where is the problem. So what kind of question will come? They will say that which of the following will lead to post-hepatic portal hypertension. Post-hepatic portal hypertension is because of Budd-Chiari syndrome. Budd-Chiari syndrome, there is a clot in the hepatic vein. They might ask that cirrhosis will lead to which type of portal hypertension. It is a sinusoidal type of portal hypertension, sinusoidal type, right? So this is what is to remember. This is a classification of portal hypertension based on the etiology: prehepatic, hepatic, post-hepatic. Hepatic is further divided into three: pre-sinusoidal, post-sinusoidal, and post-sinusoidal, right? The next is SBP, spontaneous bacterial peritonitis. Very important. If you see a patient who is having cirrhosis, because of cirrhosis, there is going to be portal hypertension. And what happens is, because of portal hypertension, look at this diagram. This will explain you the data nicely. The blood is not able to go in the liver. So the blood is accumulating here because this patient is having cirrhosis. The back pressure will come. And because of that, there is going to be inflammation in the mucosa of the intestine. And in the lumen of intestine, we have many bacteria. Right now, these bacteria are not coming out, because the intestine mucosa, it's not allowing the bacteria to come out. They remain in the intestine. But because of the back pressure of the blood, there is an inflammation in the mucosa, and the bacteria will be coming out, and they will go in the lymph node, particularly E. coli. And from the lymph node, after some time, these E. coli, they can come in the abdomen, in the ascitic fluid, in the peritoneum, and can lead to peritonitis. This is called as spontaneous bacterial peritonitis. Why it is called as spontaneous bacterial peritonitis, we are understanding, because it's because of E. coli, peritoneum inflammation is happening. Why it is spontaneous? Because this E. coli is hiding in the lymph nodes. As and when it wants, it can come out spontaneously and can create the problem. So it is called as a spontaneous problem, spontaneous bacterial peritonitis. So how the patient will come to you? If you see a cirrhosis patient is coming to you and he's saying, sir, I am having severe abdominal pain because of the peritonitis, severe abdominal pain, gorging rigidity, fever, and decrease in the blood pressure. If you see this combo, a cirrhosis patient is coming to you and he is saying, sir, I am having severe abdominal pain, fever, decrease in the blood pressure, it is SBP, but it is no other thing. It is only and only SBP. Take out his ascitic fluid and you will find the E. coli, you will find the neutrophils in his ascitic fluid. And how many neutrophils will be there? More than 250 in the ascitic fluid. How to treat this? Give the antibiotic. Plus, you will treat this an infection, but you know that this E. coli is hiding in the lymph node. After a few days, again, it can come out. We don't want this E. coli to come out because it's a very severe infection. So we want to stop the E. coli in the lymph node. And for that, we will give the lifelong antibiotics. Lifelong antibiotics will give, that is norfloxacin. Right? So this is the spontaneous bacterial peritonitis. What I want to remember, 5 words. Cirrhosis patient is presenting to you severe abdominal pain, gorging rigidity, fever, decreased blood pressure. Fever is infection. So spontaneous bacterial peritonitis. And in the ascitic fluid, you are going to see more than 250 neutrophils are there. We will give the lifelong antibiotics, norfloxacin. Right? Now, this is the SAG ratio. This is a table, a flow chart. I want you to remember. If a person of ascites comes to us, how we figure out the ascites, that why the ascites is there. We take the ascitic fluid sample, we take the sample of blood, and we send both the samples to the lab. And we ask the lab that please check in the blood, means in the serum, how much is the albumin. And in the ascitic fluid, how much is the total protein and how much is the albumin. This is what we want to ask from the lab. We will send 2 samples. If a person of ascites comes to us, we don't know why he's having ascites, maybe cancer, maybe cirrhosis, maybe heart failure. So we'll send it. And in the evening, the report will come. So we'll do the serum albumin minus ascitic albumin. If the difference is less than 1.1, the diagnosis will be any of the one. If the difference is more than 1.1, then we will check the ascitic protein. Is it more than 2.5, less than 2.5? It is more than 2.5. These are the possible diagnoses. If it is less, these are the possible diagnoses. If you can't remember the entire list, remember what I am highlighting. TB is coming here, peritoneal carcinomatosis is here, and massive liver metastasis is here. From each category, I have highlighted one. Heart failure, not HP, HF. Heart failure. These are the 4 words I want you to remember. So they will give you these 3 values. They will give you the 3 value: serum albumin, ascitic fluid albumin, and ascitic protein. And based on that, they will ask what is the diagnosis. So you have to remember this flow chart. There is no alternate to that. You need to remember this. Now coming to primary biliary cirrhosis, primary sclerosing cholangitis. What is this? These are the disease which are because of the wrong antibodies. And these wrong antibodies are damaging the bile ducts. If the wrong antibodies, the name of the wrong antibody is anti-mitochondrial antibody. Okay, tell me that. Mitochondria is a very small thing, right? It is going to found inside the liver, inside the small biliary ducts. So if there is an anti-mitochondrial antibody, the small biliary ducts inside the liver, they are going to be damaged. They are going to be blocked. And now the bilirubin cannot come out, the bile cannot come out, it will accumulate in the liver will be damaged. It is called as biliary cirrhosis. Biliary cirrhosis, because the bile is not coming out. It is an intrahepatic problem. The patient will develop cirrhosis. Whereas in the sclerosing cholangitis, as the name is indicating, cholangitis, the wrong antibodies are going to damage the big bile ducts, the common bile duct. But there is not a complete obstruction. There is no complete obstruction because the bile ducts are big. Even if there is a fibrosis, still the lumen is open. So somehow the bile will flow. So the bile is not accumulating. So there is no cirrhosis. In sclerosing cholangitis, there is no cirrhosis. If they ask that in the sclerosing cholangitis, where the obstruction is there, it can be extrahepatic, can be intrahepatic, more of extrahepatic. Right? The name of the wrong antibody is ANCA antibodies. So how to differentiate the biliary cirrhosis from sclerosing cholangitis? In biliary cirrhosis, the problem is inside the liver. The small biliary ducts are getting obstructed. Whereas in the sclerosing cholangitis, the problem is mainly outside. It may be sometimes little bit of inside of the liver also, but mainly outside, and there is no cirrhosis. If you do the biopsy, in the primary biliary cirrhosis, we are going to have the florid duct pattern, and here we are going to have the onion pill appearance. The treatment here is going to be ERCP. We will put the endoscope, we'll go inside, we'll do the retrograde, and we are going to put a stent here in this area so that it will open. That is ERCP. But here there is cirrhosis, and there is only one treatment for cirrhosis, that is liver transplant. Primary biliary cirrhosis, we need to go for liver transplant. The next is the Wilson disease, the Wilson and hemochromatosis. Again, one question I would say, maybe from patho, medicine, or little bit of biochemistry from Wilson and hemochromatosis. Either of the one question can come. Look at here, how the question will be made. First, for that, we need to understand the normal copper physiology. When we eat the copper molecules, when we eat the copper molecules gets absorbed in the intestine with the help of ATP 7A. And the 7A will absorb the copper goes in the liver, and in the liver does not want the copper actually. The liver want to throw it out. So immediately the liver will request the ATP 7B protein that please throw this copper out. And how the 7B will throw the copper out? Some copper molecules will be thrown in the bile, and some copper molecules will club with a protein called as apoceruloplasmin. The copper and apoceruloplasmin will club together with the help of 7B, and we are going to make ceruloplasmin, and we will throw it out. So there are 2 methods to clear the copper from your liver, one in the bile and second in the form of ceruloplasmin. But if the 7B is not there, that is called as Wilson disease. Now the copper will come to the liver, but neither it will come in the bile nor it will convert into ceruloplasmin. And now the copper will start accumulating in the liver, and the patient will develop hepatitis, will develop cirrhosis. And then the copper will directly come in the blood. The free copper will come in the blood. The copper can go to the brain, can go to the lens, can go to the cornea, can damage the RBCs, can damage the other organs. It is called as Wilson disease. Wilson disease is a problem of 7B, which is found on the chromosome number 13. So now the copper is unable to combine with apoceruloplasmin. So ceruloplasmin is not made, and the copper will start accumulating in the liver, then it will come in the blood, then it will go to the extrahepatic tissue. So what is to be remembered? When it comes to the test, it's very important is the investigation. Look at here. The ask is, what is going to happen with the serum free copper, serum ceruloplasmin, and serum total copper? Serum free copper increase, serum ceruloplasmin decrease. And what is total copper? Total copper means free copper and ceruloplasmin. Free plus ceruloplasmin is called as total copper. Can you tell me total copper will be more or less? Total copper will be more or less in the blood? Less. This is the interesting point. Because what is serum total copper? Free copper plus ceruloplasmin. And because the ceruloplasmin is significantly less, so the total copper value in the blood will be less. Free copper is going to be more. For the diagnosis, we are going to use the Sternlip criteria. Sternlip criteria is used. For prognosis, we use Nazar index. And can you tell me what is not a component of Nazar index? Not a component. There are three components, but what is not a component? SGOT or SGPT? SGPT is not a component. SGPT is not a component. SGPT is not a component. This is all about the Wilson disease. Then comes the hemochromatosis. Hemochromatosis is basically iron overload. Right now, whatever iron you are eating, it's not that all the iron is getting absorbed. The only that much iron is getting absorbed, which is really required for you. Only that much iron is getting absorbed. And who is stopping this excess iron to get absorbed? It is the hepcidin. On the chromosome number 6, there is a gene called as HFE gene. It makes the hepcidin. It is kind of a brake. But if the HFE gene is mutated, the hepcidin deficiency will happen. There is more iron absorption and there is iron overload. Look at here, normal how the iron physiology is there. Whatever iron you are eating, this iron comes and gets absorbed. This iron gets absorbed, then it goes to the liver. It stimulates one molecule called as hepcidin. And this hepcidin will come and it is going to put the brake. So when the iron gets absorbed, it activates the hepcidin. Hepcidin comes and it stops the iron absorption. But now the problem is when the iron is getting absorbed in hemochromatosis, the hepcidin is not there. If the hepcidin is not there, there is no one to put the brake, and a lot of iron will get absorbed. And this iron will deposit here and there in the liver, in the hypothalamus, in the skin, in the pancreas, and so many problems will happen. Right? The most common symptoms, the first symptom is going to be arthritis. The most common symptom is going to be arthritis. The iron is going to accumulate in the hypothalamus, in the pituitary. Because of that, the gonadotropins will be less. If the gonadotropins are going to be less, the testosterones will not be made and the testes will be small. So if they ask that in hemochromatosis, you tell me this answer, that in hemochromatosis, the testes are small, is because of iron accumulation in the testes, or there is no involvement of the iron, no accumulation of the iron in the testes. Why the testes are small? What is the problem is happening? Why there is hypogonadism? It is not the testicular problem. It is a problem in the pituitary. The hypothalamus and the pituitary, there it is accumulated. That is creating the problem. It's not the direct testicular problem. There is no iron. This is important negative statement. There is no iron deposition in the testes, in the gonads, and in the brain. There is no. In fact, for Wilson disease also, there is one negative statement. In Wilson, which organ is not involved? Can you tell me in Wilson, which organ is not involved? Where the copper does not accumulate in Wilson? In Wilson, which organ is not involved? Brain, eye, parotid gland, salivary glands, where it is not involved? In the Wilson, heart is not involved. Cardiovascular system not involved. In Wilson disease, the cardiovascular system is not involved, whereas in hemochromatosis, the brain, the central nervous system is not involved. Not involved. Now coming to the vitamin B12, how the vitamin B12 absorption happens and how the malabsorption of B12 will happen. When you eat the B12, vitamin B12, the moment it will come in the oral cavity, in the saliva, we have a molecule called as heptocorrin. The moment the heptocorrin will see the B12, it is kind of the love at first sight. The B12 and heptocorrin will fall in love at first sight. But heptocorrin can't say it. Heptocorrin is shy. So what is going to happen is wherever the B12 will go, the heptocorrin will also follow. When both will reach to the stomach, in the stomach, from the chief cell, one molecule comes pepsin. Pepsin is a friend of heptocorrin. He will ask heptocorrin, what you are doing here? You should be in saliva. The heptocorrin said that here is the B12 and I like B12, but I'm not able to say her. So the pepsin say, oh, B12 is my friend. So now the pepsin is going to work like a mediator and it is going to do the patch up for the B12 and heptocorrin. And now both are together. They are happy. It's heptocorrin actually who is more happy compared to B12. And they are putting the photos here and there. They are roaming and going forward, enjoying roaming here and there. When they are roaming, there is one molecule comes from parietal cell, that is intrinsic factor. When the intrinsic factor looks at the B12, he also falls into love for B12. But right now the B12 is with heptocorrin. So now the intrinsic factor can't do anything. But what the intrinsic factor will do, the intrinsic factor is going to follow the couple. Wherever this couple will go, the intrinsic factor is going to follow. And what is going to happen is in the duodenum, the friend of the intrinsic factor is there called as protease. The moment the protease will come, the protease will say, intrinsic factor, what you are doing here? The intrinsic factor say that I will love her, but I can't say. So the protease is going to create a misunderstanding between the couple. And for some time, this couple will separate because of protease. The moment this happens, the intrinsic factor is going to grab the B12. And now the intrinsic factor and B12 are together. And then they will go forward. In the terminal ileum, we have a trap for intrinsic factor with the name of cubulin. The moment the intrinsic factor is absorbed, along with that, the B12 is also absorbed. So if I ask you that for the B12, there were two lovers. What are the names of these two lovers of B12? What are the name of two lovers? Heptocorrin and intrinsic factor. And we have the two friends. The friend of heptocorrin is pepsin. The friend of intrinsic factor is protease. So can I say like this? If you want to absorb the B12, you require three things. You require three things. What are the three things you require? You require intrinsic factor, you require protease, and you require terminal ileum, the cubulin receptors. If the three things are working, you can absorb B12. If intrinsic factor, protease, or cubulin receptor, if anyone is not having a problem, you can't absorb. And for the B12 malabsorption, which test we are going to do? Schilling test. Schilling test is done if there is B12 malabsorption. The next is the the celiac sprue. When you eat the wheat that contains the gluten, gluten is a protein. Gluten, inside the gluten, we have a molecule called as gliadin. So actually, whenever we are eating the wheat, we are eating the gluten or gliadin. This gluten gets absorbed in the intestine, and in the intestine, we have one enzyme called as TTG, tissue transglutaminase. What it will do is it will convert the gluten into a deaminated peptide. And this deaminated peptide is very antigenic because what happens is, look at here. See, can I say that you tell me yes or no that the antigens are made up of protein? Yes or no? Antigens are made up of protein. Yes or no? Yes, antigens are made up of protein. Gluten is a protein. Now, when we eat the gluten, the immune system does not make the antibodies. Although it is deaminated peptide, but still the immune system will not make the antibodies. But in some children, those who have this HLA DQ2, DQ8, they are going to make the antibodies against the gluten. And just not gluten, they are going to make the antibody against the TTG, against the gliadin, against the endomysial. They are going to make a lot of antibodies and they are going to damage the small intestine. They will damage the other organs also, such as the skin. There's going to be dermatitis herpetiformis, the kidney, autoimmune hepatitis, pancreatitis. There are many other diseases will happen. This is called as the celiac sprue. In the celiac sprue, the main question is that when you do the biopsy of the small intestine, what you are going to see, because these antibodies are going to damage the small intestine. Normally on the small intestine, we have a lot of villi like this. This is normal, but in the celiac sprue, the villi are gone. There is going to be villus atrophy, and on the small intestine mucosa, we will see a lot of lymphocytes. There is going to be lymphocytic infiltration. The villus atrophy with lymphocytic infiltration will be there. This is the important question from celiac sprue. What is the treatment in the celiac sprue? We will tell the patient that the parents that don't give gluten to your child. We have to give gluten-free diet, that is MRCP or MRCS. MRCP means the maize, rice, corn, potato. We'll give it. or S stands for soya milk. We can give all these things for 6 to 12 months. If it works, very good. If not, then we have to give steroids. What is to be avoided? Bro is to be avoided. We should not give bro, barley, rye, oat, wheat should be avoided. Then comes the ulcerative colitis and the Crohn's disease. Both are the inflammation in the intestine. Ulcerative colitis is a superficial inflammation. It's a superficial inflammation. It's a continuous inflammation. It is going to start from the rectum. Whereas in the Crohn's disease, it is going to be deep inflammation. It is going to be skipped lesions. It is going to skip. It's going to be deep. And mainly it is going to happen in the small intestine. So in both of them, there is an inflammation in the intestine. So it's called as the inflammatory bowel disease. But in the ulcerative colitis, because the inflammation is starting from the rectum, so the bleeding happens in the rectum and the fresh blood comes in the stool. So whenever there is a question of ulcerative colitis and Crohn's disease, one of the important method by which we differentiate the color of the stool. If they say fresh blood is coming in the stool, the pus is coming in the stool, it is ulcerative colitis. Whereas in the Crohn's disease, the bleeding is happening in the small intestine. So by the time the blood will come in the stool, it is going to change the color. So this is how we differentiate. So now I have a question for you that in ulcerative colitis or Crohn's disease, which disease is going to mimic like a dysentery? Which disease is going to mimic like a dysentery? Dysentery means diarrhea with bleeding, right? So which disease is going to mimic like dysentery? Ulcerative colitis. Because in ulcerative colitis, we are going to have the diarrhea, the fresh blood will be coming in the stool. So here it is written that ulcerative colitis is going to mimic the Campylobacter jejuni dysentery. Plus, in Crohn's disease, the inflammation is so severe, the deep inflammation happens. So, for example, here is the intestine, here is the stomach, and then is the small intestine. In the Crohn's disease, wherever the inflammation happens, around that inflamed area, the fat is going to come and accumulate. And this is the wrapping of the fat that is going to happen around the intestine like this. This is the fat wrapping that is going to happen. And the inflammation is so deep that it is going to create a fissure, sometimes fistula also. There's going to be cobblestone appearance will be there. These are the things, the creeping fat, the fat wrapping, the fissure, the cobblestone appearance like this. This is seen in the Crohn's disease. Crohn's disease. In ulcerative colitis, we are going to have the fresh blood in the stool, the mucus in the stool. If they say appendectomy and smoking, they are the risk factor for ulcerative colitis. No, they are protective. It is seen that if a person has underwent appendectomy, there is less chance of ulcerative colitis. If a person is smoker, there is less chance of ulcerative colitis. If they ask that fistula, obstruction, pain, it is going to more happen in the Crohn's disease. More happens in the Crohn's disease. Okay, which thing is going to respond to antibiotic? What happens is in Crohn's disease, it's an intermittent inflammation that is happening here and there. Patchy inflammation is happening. So there is a response that can come from the antibiotics. Because in Crohn's disease, there is bacterial infection also happens. In ulcerative, we don't have bacterial infection, but in Crohn's, we have bacterial infection. So when we give antibiotic in the Crohn's disease, the patient feels better. In the ulcerative colitis, there's going to be fine granular ulcers. The collar button shape is going to be there, whereas in the Crohn's disease, there's going to be deep aphthous shape ulcers will be there. This is the lead pipe appearance that is seen in ulcerative colitis because the entire colon is going to be involved. There is no hostra or coli will be visible like a pipe, it will be there. The large intestine may look very big. This is called as the toxic megacolon that is seen in ulcerative colitis. In the Crohn's disease, we are going to have the string sign of contour, the white fibers like structure will be there. We will have the rose thorn appearance because the dye will go in these small fissures. So it is going to look like this. This is the rose thorn appearance. Rose thorn appearance. How to treat the patient? In ulcerative colitis, we generally start with 5-aminosalicylic acid. If it doesn't work, we'll go for steroids. And then if not, we'll go for surgery. In ulcerative colitis, we can do a surgery because it's only involved the large intestine, so we'll remove the large intestine. But in the Crohn's disease, first we'll go for total parenteral nutrition. We'll stop the food orally. We will just give IV fluid and steroid. Once the patient becomes stable, this is the induction. Then for the maintenance, we'll give the 5-aminosalicylic acid. If it doesn't work, we can give monoclonal antibodies also. It is difficult to control Crohn's compared to ulcerative. Ulcerative can easily be controlled, Crohn's difficult to control. Total parenteral nutrition. TPN stands for total parenteral nutrition. Now, these are the scoring systems in the gastrology. I don't want you to remember all the components, but at least remember the indications. For example, what is the indication for PELD? PELD criteria is for what? It is the liver transplant criteria for the pediatric patient, PELD criteria. Glasgow criteria. Glasgow criteria is for the prognosis of alcoholic hepatitis. Milan criteria, if the person is having cirrhosis and cancer both, whether to do the liver transplant or not, will use the Milan criteria. Metavir criteria is to see that how severe is the fibrosis in the cirrhosis patient. Discrimination factor is to decide that whether to give the steroids in the alcoholic hepatitis patient or not. In the same way, we have discussed about the MELD criteria also. MELD is also to decide whether to give the steroid or not. MELD is used for many other things also, but one of them is to initiate the steroid in the alcoholic hepatitis or not. So at least remember this much. If you can't remember the component, no problem, but at least remember Milan is for what, Metavir is for what, discrimination is for what. Now coming to the rheumatology. The first is the SLE. One thing I want you to understand here in the SLE is you may have seen that in SLE there are all the organs are getting involved: skin, liver, lungs, heart, anything can involve. How it is possible that we understand that it's a wrong antibody which is damaging the organ, but how we can have such an antibody which can damage all the organs? Can I say that we have DNA in all the organs? Yes or no? We have the stones in all the organs? Yes. So if I make a wrong antibody against the DNA, wrong antibodies against the histones, ribosomes, then yes, these wrong antibodies can damage any organ. And this is what is happening in SLE. What are the names of the antibodies do you have in SLE? Anti-DNA, double-stranded DNA antibody, anti-histone antibody, anti-ribosome antibody. These wrong antibodies can damage these things, and they are there in the entire body, every cell. So technically, SLE patient, these wrong antibodies can damage any cell, right? But why it is not happening in you and me? See, what happens is when a cell dies, that is called as apoptosis, the DNA and everything comes out. And these are called as apoptotic material. This apoptotic material is very antigenic. The DNA is there in the blood and it comes in the contact of immune system in you and me. But the immune system will not make the antibody because we remove these apoptotic materials, the fragment of the DNA, the vestige of the stones, we remove from the blood immediately with the help of complements. If the complement clearance is not happening and the apoptotic material will remain in the blood, then the immune system will get the time to see these antigens and to make the antibodies, right? So here it is written that when there is more apoptosis happening, if there is increase in the number of apoptosis, it may be because of TREX gene, it may be because of UVB rays, silica, mercury, some drugs, some complement deficiencies are there. There is apoptotic bodies are not cleared. Then these apoptotic bodies will be given to dendritic cells, then to the T cells, then to the B cells, and we will make the antibodies. And then the problem will start. This is called as SLE. So SLE is because of two things. In SLE, the problem is there is more apoptosis happening, plus the clearance is not happening. So the apoptotic body remains in the blood and we make the antibodies and we damage any of these organs. What are these wrong antibodies? The name of these wrong antibodies to be remembered, the most sensitive is the ANA test. The most specific is the anti-Smith antibody. The investigation of choice, anti-DS DNA antibody. The drug-induced SLE is seen if a person is having anti-stone antibody. What are the drugs that is associated? It is the SHIP drug, sulfonamide, hydralazine, isoniazid, procainamide. The SHIP drugs are associated with that. If the mother is having the SLE and the newborn, the pregnant mother, the lady was there, and the newborn is also having the SLE, how it is possible? If the mother is having anti-Rho antibody, anti-La antibody, they can transfer through the placenta, anti-Rho, anti-La. They can go to the child and can create the problem in the child. If the SLE patient is having psychosis, which antibody can damage the brain of SLE? That is anti-ribosomal antibody. Cerebritis can happen if there is anti-neuronal antibody. The recurrent abortion can happen if there is anti-cardiolipin, anti-glycoprotein, anti-phospholipid antibody. So The point is, in the SLE, there are different organs can be involved. It depends that which wrong antibodies are there, and you have to remember this list. What is the drug-induced neonatal lupus, psychosis cerebritis, nephritis? Nephritis is because of C1q antibody. For the diagnosis, we use a criteria called as SLIS criteria. There are some clinical features, some investigations. So at least 4 of them should be there. Some clinical features, some investigation should be positive. Then we'll make the diagnosis of SLE. The next is the scleroderma. As the name is indicating, the skin is becoming hard. Scleroderma. There is a sclerosis of the skin. When we talk about the limited scleroderma, that is called as the CREST syndrome, the acronym is there is calcinosis cutis. There is deposition of calcium in the skin like this. On the X-ray also you can see the calcium is there in the skin. Calcinosis cutis. There is Raynaud's phenomena, esophageal dysmotility. The esophagus is becoming hard. Sclerodactyly, the fingers are becoming hard, and telangiectasia. If we see this combination, telangiectasia, this dysphagia, Raynaud's phenomena, it is the limited scleroderma. We have the extensive scleroderma also. We have the limited scleroderma. Limited means the wrong antibodies are making the skin and the mucous membrane hard, but in the limited areas. But if the extensive involvement is happening in the lungs, in the other organs, that is extensive diffuse scleroderma. When it comes to the extensive diffuse scleroderma, it is due to anti-SCL70 antibody. So limited scleroderma, anti-centromere antibody, diffuse scleroderma, it is going to be the anti-SCL70 antibody. When it comes to the Sjogren syndrome means the wrong antibodies are damaging the glands. The anti-Rho antibody, anti-La antibody, they damage the glands, the parotid and salivary glands, the lacrimal glands. So the patient is having the dry eyes, dry mouth. If the dry eye, dry mouth, dry skin, dry mucous membranes, the recurrent pneumonia is happening. If these things are mentioned, this is going towards Sjogren. But do you know that anti-Rho antibody, anti-La antibody we have discussed in one more disease? Can you tell me which disease? SLE or scleroderma or CREST syndrome, where we have discussed about Rho and La antibody? Yes, we have discussed in the SLE. So Sjogren syndrome can happen because of SLE also. If the SLE is leading to Sjogren syndrome, it is called as secondary Sjogren. If without SLE you have the Sjogren, it's called as primary Sjogren. So the Rho and La antibody, it can damage the glands. Or if a patient is coming to you and he's saying, sir, I am having dry mouth, I am having the dry eyes, it is going towards the Sjogren. It may be primary, it may be secondary. The primary Sjogren increases the risk of lymphoma, particularly maltoma. There is increased risk of maltoma. And how you will figure out? So whenever a person is having primary Sjogren, we know that anytime it can convert into cancer. So we regularly check his neutrophil count. If the neutropenia starts happening, it's a precursor of cancer. And they ask this question. Secondary Sjogren does not lead to cancer. Primary Sjogren can lead to cancer. How to find out? Regularly check the neutrophils count. If there is neutropenia is happening, yes, it is converting into cancer. Then comes the ankylosing spondylitis. Ankylosing spondylitis, it is associated with the HLA B27, mainly happening in the young males, 20-30 year of age. It is going to start from the sacroiliac joint. All the vertebrae are going to fuse together like this. Look at the normal vertebrae. Normally the vertebrae are free from one another. So we have a very good movement in the vertebral column. But if the vertebrae will fuse together like this, then this is called as the syndesmophyte. And all the vertebrae will convert into a single rod-like structure. This is called as the ankylosing spondylitis. Ankylosing means fusion. All the vertebrae are fusion together. The first joint where the problem is going to start is sacroiliitis. This is the first joint where the problem will start, and then slowly this disease will ascend up. Initially, the patient will have low back pain. Then the lumbar will involve. There is decrease in the forward bending. Then the thoracic involve. So there is decrease in the respiratory effort. The cervical involved, and then the fracture will happen. It's a very bad disease, very bad prognosis. And this disease is just not going to damage the joints. There's going to be extra articular problems also, such as anterior uveitis, diarrhea, chronic disease anemia. These things will happen. You may have heard about the word seropositive, seronegative. What is seropositive, seronegative is if a person comes with joint pain and RA factor is positive, that is called as the seropositive arthritis. So sero means RA factor. If the RA factor is there, it's a seropositive arthritis, that is rheumatoid arthritis. If the RA factor is negative, it is called as seronegative. And what are the seronegative arthritis? Ankylosing spondylitis, Ritter syndrome, enteropathic arthritis, psoriatic arthritis, they all are seronegative. So if a patient is presenting with the joint pain, but the RA factor is negative, it's seronegative. Then how you will find out whether it is ankylosing spondylitis or Ritter syndrome? If they give you that there is a young male, he is having low back pain, it is ankylosing spondylitis. If there is a history of UTI, now the patient is presenting with conjunctivitis, UTI, joint pain, then it is Ritter syndrome. If there is a history of ulcerative colitis, means blood in the stool, ulcerative colitis is there, and now joint pain, it is enteropathic arthritis. If there is a silver scaly appearance, means there is psoriasis is there, and now the patient is presenting with the arthritis, it's a psoriatic arthritis. In the psoriatic arthritis, we are going to have the sausage-shaped finger. The finger is going to look like a sausage. In the X-ray, we are going to have the pencil in cup appearance or the opera glass deformity. And the treatment is going to be the TNF alpha inhibitors. Right. So when it comes to seropositive, seronegative, this again flow chart is important. If they say RA factor is positive, it's seropositive. If the RA factor is negative and the patient is presenting with the joint pain, it may be ankylosing, Reters, enteropathic, or psoriatic arthritis. Sometimes in the TB patient, also we can have the joint pain that is called as the Ponset disease. Now comes this difference: microscopic polyangiitis, eosinophilic polyangiitis, and the granulomatous polyangiitis. This granulomatous is also referred as the Wegener's, the Churg-Strauss, right? So how we will differentiate them? How to differentiate the Churg-Strauss from the Wegener's? The old name is Wegener. Here is the Churg-Strauss. Now look at here. I will give you 5 buzzwords. You don't have to remember this entire table. Just look at me and I will tell you how to make the diagnosis. MPA is microscopic polyangiitis, eosinophilic polyangiitis, and the granulomatous polyangiitis. What is happening in all of them? There is inflammation in the blood vessels. The small blood vessels are getting inflamed. MPA, EPA, GPA. They love to ask the difference. They love to ask difference. See how I will solve the question. E stands for eosinophils. Eosinophils associated with allergy. If they say the small blood vessels are having inflammation and bronchial asthma is mentioned, means allergic disorder is mentioned. If eosinophil means asthma, asthma is mentioned with polyangiitis, eosinophilic polyangiitis. If they say there is no asthma, but they say that there is, and one more interesting thing, that in the EPA, there is no kidney involvement. There is no kidney, because it's a pure asthma disorder, it's pure lung disorder. But in MPA and GPA, you can see that there is an involvement of the lungs, there is an involvement of kidney both. Lungs and kidney both are involved. Then how you differentiate MPA from GPA? With the C ANCA and P ANCA. If the P ANCA is there, it is MPA. If the G ANCA is there, C ANCA is there, it is GPA. There are some additional features are there in the eosinophilic ones. There is going to be mononeuritis multiplex, the myocarditis, the GI involvement. These are some of the features, but that is not very important. So let's summarize. What is to remember? You try to give this answer. MPA, EPA, GPA. If I say small blood vessels are getting involved and the asthma word is mentioned, allergic word is mentioned, eosinophil word is mentioned, it is EPA, Churg-Strauss. But if they are not mentioned, but along with that, they are saying that kidney involvement is there, the lung involvement is there, then it may be MP or maybe GPA, right? Then how you differentiate C ANCA, P ANCA? That is one difference. Second, granulomas. Granulomas are seen in these two conditions. EPA, GPA has the granuloma. MPA, no granuloma. So that is one more thing by which you can differentiate. There are 3-4 words that you need to remember. Based on that, you will make the difference. Now, one more thing here. Look at here, this one, Wegener's and good pasture. How you differentiate Wegener's, good pasture? In both of them, you have the kidney and lung involvement. One difference is the C ANCA. C ANCA and lung cavities, they are seen in Wegener's. In good pasture, you don't have C ANCA, you don't have lung cavities. If they have mentioned hepatitis B, and they are saying that the patient is having some type of vasculitis, hepatitis B leads to 2 types of vasculitis: microscopic polyangiitis and polyarteritis nodosa. There are 2 arthritis happens because of hepatitis B. If there is lung involvement is there, it is MPA. If there is no lung involvement, it is PAN, polyarteritis nodosa. This, I feel, if you can't remember all of them, Just remember 5 words. You give me these 5 answers and we are done with the vasculitis part. Give me 5 answers. The options are EPA, MPA, GPA, and PAN. If I say asthma, what is the answer? If I say asthma word with vasculitis, if the options are saying EPA, GPA, MPA, and asthma is mentioned in the question, the answer is EPA, eosinophils. If I say granuloma, if I don't use the word asthma, but if I say granuloma, then you have to see that P Anka or C Anka. If I say granuloma with P Anka, what is the answer? Granuloma with P Anka, what is the answer? Granuloma with P Anka, then this is the EPA, the eosinophils. Granuloma with C Anka, Vagnus. If I say hepatitis B, there are two possibilities, MPA or PAN. Differentiation, lungs. In PAN, the lungs are never ever involved. The PAN can never go to the lungs. If you can't remember anything, just remember this one word. In the PAN, the lungs are never ever involved. If they specifically say hepatitis B word is mentioned and they are saying that which vasculitis is there, it may be MPA, maybe PAN, lung involvement is there or not there. Right? Now coming to the endocrinology. When it comes to the fasting sugar, the normal should be up to 99. 100 to 125 is pre-diabetes. More than that is diabetes. So they love to ask 100 to 125 is the pre-diabetes. Pre-diabetes. Do you want a break? Do you want me? वैसे तो आपका break ही चल रहा है. You can take the break anytime. It is actually not for you. It is for me. Right? आप तो ले सकते हैं break कभी भी. Right? आप आराम से बीड़ी पीते पीते भी देख सकते हैं. चाय पीते पीते देख रहे हैं, बीड़ी पीते पीते, सोते सोते भी देख रहे होंगे बहुत सारे. आप यस यू आर राजा. राजा तो कर ही सकता है. बस थोड़ा सा बचा है. It will not take much time. Maybe half an hour more and we'll be done. Not much. Just half an hour. So it was almost 3.5, 4 hours discussion and we'll be done. Let's come to the endocrinology. Yes, no need to break, right? Yes, I will be sharing the PDF with you guys. Obviously, I will be sharing it with you. Because without this, I understand that you are not able to write so fast. Just a minute. Am I visible, audible, guys? All fine? Okay. अरे बीड़ी पीने नहीं गया था भाई. No बीड़ी, no cigarette. The server was down actually. I was not planning to take a break, but the server was down somehow. मतलब ऊपर वाला चाहता था कि हम ब्रेक ले लें. That is why. The black magic. Someone has did the black magic with the server, like they do in the class also. Okay, let's do the endocrinology. So when it comes to the pre-diabetes, it is going to be 100 to 125. Less than that, it's going to be normal. More than that, it's diabetes. Whenever you see a table, and in that there are three columns are there, always try to remember the center one because they are going to ask the center one only. The examiner knows that if you know the center one, then automatically you know the first and the last one, right? So they love to ask the pre-diabetes part. It's 100 to 125. The best test for diabetes is going to be HbA1c, but we don't test the HbA1c a lot because HbA1c depends on the glucose as well as it depends on the hemoglobin and the RBC lifespan. So if a person is having anemia, the hemoglobin is less, the HbA1c will be falsely high, falsely high. In the polycythemia, the HbA1c will be falsely low. If a person is having hemolytic anemia, in the hemolytic anemia, the RBC lifespan becomes very less. So actually what the HbA1c is telling us that how much interaction is happening between the glucose and RBC. If the RBCs are dying very fast, there is very less interaction will happen. And very frequently the RBCs will replace with the new one. And in that case, the HbA1c, the surface area that is covered by the glucose molecules will be very less. So the HbA1c depends on the RBC lifespan. It depends on the hemoglobin levels. So whenever we see the HbA1c, we always want to see the status of the RBC. We want to see the status of hemoglobin. Then only the report is valid. Then when it comes to some of the complication and the diagnostic, some more part is when it comes to the drugs for the diabetes, we use the biguanides, that is going to be the metformin. It asks that how the metformin works is metformin is going to decrease the hepatic gluconeogenesis. But what they love to ask is not the mechanism, mainly they love to ask the side effect. The metformin, one of the side effect is it can lead to B12 deficiency. Metformin can lead to lactic acidosis. Then there is the drug called as sulfonylureas. The side effect of sulfonylurea, it can lead to hypoglycemia. The glimepiride, gliclazide, glyburide. If you see the acarbose alpha glucosidase inhibitor, they leads to abdominal cramp. When we talk about the PPAR gamma, the pioglitazones, they are cardiotoxic. They increases the risk of bladder cancer. The GLP-1 analogs, that is exenatide, liraglutide, the side effect is it can lead to pancreatitis. They ask that which is the most renal safe gliptin, most renal safe DPP4 inhibitor. It is linagliptin. Then if I ask you a question that a person is having diabetes with CKD, what is the best treatment for diabetes? If a person is having diabetes with CKD, what is the treatment you will give for diabetes? You will give metformin, you will give linagliptin. What is the best treatment? The best treatment is going to be insulin. Any day, the best treatment for diabetes with any complication is going to be insulin. And diabetes with CKD, how much insulin you will give? You will give full dose, you will give half dose, you will give 80%, 70%. How much you will give? You will give 80% of required dose. 80% of required dose. Don't worry about the PDF. Yes, I will be giving the PDF to you. Right? Obviously, you are not able to write all these things, so we'll be providing it to you. When it comes to the next is the diabetic ketoacidosis. If you see a patient of type 1 diabetes is coming to you, that is a young patient. In type 1 diabetes, we need to give insulin in the treatment. So if a type 1 diabetes patient is coming to you and he is insulin defaulter, he is not taking the insulin for some time, for 2 days, 3 days, and now he's coming to us with abdominal pain, nausea, vomiting, altered sensorium. If the patient is coming like this, we should always suspect of DK. Whenever a type 1 diabetes patient stops taking the insulin, he can go into diabetic ketoacidosis. In diabetic ketoacidosis, what is the diagnostic criteria in the diabetic ketoacidosis is the glucose will be more, should be more than 250. The ketones should be present. So diabetes, the sugar should be more than 250. Ketones should be there in the urine. And in the ABG, there should be acidosis. These three things should be there. This is the diagnostic criteria. There are some other features can be there. The sodium can be less, amylase can be more, but the first and the foremost thing to be given in the treatment is IV fluid, because if you give IV fluid, the dehydration will be taken care. Plus, the ketones will be washed out. If you give IV fluid, a lot of urine will come and the ketones will be washed out. Along with that, the decay has happened because the patient was not taking insulin, so we'll give insulin. And which insulin will give? Regular type of insulin we are going to give. Whenever we give insulin, always take care of potassium, because of insulin the potassium can be less, so we'll give the potassium supplement. If the ABG is showing the pH is very less, then we can give sodium bicarbonate, that is the alkaline molecule. If they ask that what is the most common cause of death in the DK patient, the most common cause of death is going to be cerebral edema. The mechanism is not important, so I am not explaining that. The most common cause of death is cerebral edema. In contrary, if they say a type 2 diabetes patient is coming to us, means old age patient is coming to us, and she is also treatment defaulter. There is a type 2 diabetes patient and not taking the medication for a long time. Right now, she is presenting to us with altered sensorium. When we check his blood glucose, the blood glucose is very high. The blood glucose is, for example, 500, 600, 700, very high. The moment you see this combination, type 2 patient is presenting with altered sensorium, seizures, blood glucose is very high. This is hyperglycemic, hyperosmolar state. Hyperglycemic, hyperosmolar state. Right? Yes, it has a very poor prognosis. Then comes the thyroid profile test. Thyroid profile test. Whenever the thyroid profile test comes, we always first see the T4. The T4 is less or more. If the T4 is less, it's hypothyroid. If the T4 is more, it's hyperthyroid. So it's very easy to find out hypo and hyper. If the T4 is less, it is hypo. If the T4 is more, it's hyper. Then how to differentiate? It's primary or secondary. Primary means the problem is in the gland itself, means in the thyroid gland, or the problem is in the pituitary. How to find out where is the problem? So we will see the TSH. If the T4 and TSH is running in the same direction, for example, if you see this one, the T4 was less, so it was hypo, and the TSH is also less. If the arrows are running in the same direction, same means secondary. If the arrows are running in the same direction, it's secondary. If the arrows are running opposite, if the T4 is less and the T4 is TSH is more, it's opposite. It's primary. So first, how to decide hypo and hyper with the help of T4. And primary, secondary, if the arrows are same is secondary, opposite is primary. If the T4 is normal, then it's a subclinical condition, subclinical hypo and subclinical hyper. If there was a problem in the thyroid gland, it was working less, so the T4 decreased, but the pituitary has sent a lot of PSH, a lot of TSH, and somehow the T4 returns to normal. It is called a subclinical hypo. Subclinical hypo. So this is how we differentiate the primary from secondary. When it comes to the hyperthyroid, in hyperthyroid, we have a very peculiar eye sign. In hyperthyroid, what happens is there is more contraction happens in the upper eyelid. there is more contraction. Normally, you will notice that we are unable to see this part of the cornea. Normally, this is not visible. But in hyperthyroid, there is more contraction in the upper eyelid. So this part of the cornea, this part of the sclera is visible. This is seen in hyperthyroid. There is more contraction in the upper eyelid. This is called as Abadi sign. There is more contraction in the upper eyelid. It's called as Abadi sign. And because of Abadi sign, what happens is there is more contraction. It's called as Abadi. Because of that, the entire cornea is visible. It's called as Del dimple sign. And it looks that as if the patient is staring at you. The patient is staring at you. This is called as Talweg sign. The patient is having the staring. When you tell this patient to look downward, means we tell the patient, don't move your neck and try to look at the floor. Right now, you also can do that. Don't move your neck and try to look at the floor. The moment you try to do this, the moment your eyeball will go down, your eyelid is also coming down. But in this patient, what happens is, because there is more contraction in the upper eyelid, when they look down, the eyeball will go down, but the upper eyelid is still there. After 2-3 seconds, it will come down. There is a lag. There is a lag in the movement of the upper eyelid, and this lag is called as the von Graffe sign. So in hyperthyroid, we have many eye signs are there because there is more contraction in the upper eyelid called as Abadi sign. Because of Abadi, the entire cornea is visible. It's called as Del dimple. There is going to be a lag in the movement of the upper eyelid called as von Graffe. There is loss of forehead wrinkles called as Joffrey sign. There is staring look is called as Talweg sign. They are unable to move the eyeball inward called as Mobius sign. So there are many eye signs are there in the hyperthyroid patient. Then if you see a patient, and this is a very important question, it's easy but important. If you see a 40-50-year-old female patient is coming to you and they are saying that there is a history of viral fever, the lady has developed some kind of viral fever few days back, she has recovered, but now she's coming, she's saying, sir, I am having severe pain in this neck area because she's having a reactive inflammation in the thyroid gland. So after viral fever, sometimes there is a reactive inflammation in the thyroid gland. The thyroid gland becomes big, swollen, inflamed. It is called as subacute thyroiditis. So viral fever followed by pain in the thyroid gland, it's subacute thyroiditis. What is the treatment? We can give steroid, a short course of steroid. Then what is the how to make the diagnosis of grave disease? If there is hyperthyroid, if the hyperthyroid features are there, plus there is diffuse smooth goiter, means the entire thyroid gland is increased in the size. The smooth goiter is there. Smooth goiter, plus there is proptosis. Proptosis is due to accumulation of the gag molecules behind the eyeball. Sometimes the gag molecules deposits, so the eyeball comes out, or pretibial myxedema. Pretibial myxedema. If this happens, if a patient is presenting to you, the thyroid gland is big, hyperthyroid features are there, and the eyeball is coming out because the gag molecules deposition, the moment you see gag, it is grave disease. Grave disease. Now, one more point I want to add it here. We have some space available here. Let us use it. This one. When it comes to the radioactive iodine uptake test from the radiology, we use the iodine 123 for that test. If there is a thyroiditis or if there is grave disease, if there is thyroiditis, there is going to be decrease in the homogeneous decrease in the uptake. The entire thyroid gland will take less iodine. There is going to be homogeneous decrease in the radioactive iodine uptake. And in the grave disease, there is homogeneous increase in the radioactive iodine uptake. Homogeneous increase or decrease in the radioactive iodine uptake test, thyroiditis and the grave disease. How to differentiate the primary hyperaldo from secondary hyperaldo? As the name is indicating, hyperaldo means more aldosterone. Whenever the aldosterone is more, aldosterone is the hormone that pulls the sodium from the urine and throws the H plus and K plus in the urine. If the aldosterone is more, the sodium will be more. If the sodium is more, the blood pressure is going to be more. And because the aldosterone is going to pull the sodium and will throw the H plus and K plus out, if the H plus will go out, there is going to be alkalosis. K plus will go out, there is going to be hypokalemia. So primary hyperaldo and secondary hyperaldo, whenever the aldosterone is more, these things are going to be happening. Then how to differentiate? Actually, what is primary and what is secondary? Primary hyperaldo means the problem is in the adrenal gland and the aldosterone is increasing. It's primary. If the problem is somewhere else, let's say the problem is in the pituitary gland, the problem is in the heart, problem in the liver, somewhere else is the problem, and the aldosterone is increasing, it's secondary. So how to differentiate? One is the pedal edema. In the primary, you don't have pedal edema. Secondary, you have pedal edema. And one more. In primary, the renin is less, and in the secondary, the renin is more. And I told you one simple hint in the endocrinology. In secondary, as for secondary, the arrows will be same. Hyper eldo is more, and renin is also more. In secondary, the arrows are same. In secondary, the arrows are same. Eldo is more, renin is also more. But in primary, the arrows are opposite. Eldo is more, but renin is less, right? So this is how we differentiate from primary from secondary. Then comes the pheochromocytoma, the hot favorite topic of that board, pheochromocytoma. It's a tumor of chromaffin cells, also called as chromaphinoma. It is going to release a lot of noradrenaline and adrenaline. That is going to increase the sympathetic activity. But the good thing about this tumor is not regularly releasing the adrenaline and noradrenaline. This tumor makes the noradrenaline and adrenaline and it stores. And after some time, it is going to release. So every 2 hour, every 3 hour, it is going to release. Every 2 hour, every 3 hour, it is going to release the noradrenaline and adrenaline. And then uh, the symptoms will come. But the noradrenaline and adrenaline, that is just going to work for 5 to 10 minutes. And after that, we break it, we throw it out. When you break the noradrenaline, we are going to make the normetanephrines. When you break the adrenaline, you will make the metanephrines. From the metanephrines, you can make the vanillyl mandelic acid also. So these things are going to be more in the urine and the blood of this patient. The metanephrines, the vanillyl mandelic acid. The pheochromocytoma, the symptoms are going to be episodic. It's not going to be continuous because this tumor is not releasing the adrenaline continuously. The moment it will release, there's going to be increase in the blood pressure, heart rate, sweating. So the symptoms are going to be episodic. And this is the classical triad: headache, palpitation, sweating. There's going to be increase in hematocrit. There's going to be weight loss, hypercalcemia will be there. In the screening test of choice, urine metanephrines. The investigation of choice, plasma metanephrine. And this was the question: how to find where is the tumor? Because there is a rule of 10. 90% of the time, adrenal gland. 10% of the time, outside adrenal gland. So we'll do the MRI abdomen. We'll have the light bulb sign. Because it's a very vascular tumor, so the FNSE is avoided. We never do FNSE in that. How to treat this? We have to remove the tumor, but we don't do the surgery immediately. First, we give some drugs to block the alpha and beta receptors. First, we are going to block the alpha receptor. From Monday to Thursday, we'll give phenoxybenzamine for the first 4 days. And then Friday, Saturday, Sunday, we'll give alpha and beta blocker both. And then we will do the surgery. But after the surgery, there's going to be darkening of the skin. And that is called as Nelson syndrome. So these are the 3 questions which has came in a single paper. How to localize the tumor? MRI. Which is the first drug to be given? Alpha blocker. And after the surgery, the patient will become dark. That is called as which syndrome? Nelson syndrome. For finding out the extraadrenal pheochromocytoma, we can do DOPA-PAT. For finding the metastasis of pheochromocytoma, we can do MIBG scan. So these are some of the important questions from pheochromocytoma part. Then comes the Cushing syndrome. There is going to be increase in the cortisol. It's called as Cushing syndrome. What they ask is 2 questions. One is the etiology. The most common cause is going to be the iatrogenic. The patient is eating the cortisol tablets from outside. The second most common is going to be a pituitary tumor. This pituitary tumor is making a lot of ACTH, and because of ACTH, there is going to be increase in the cortisol. When it comes to the screening test of choice, we are going to see the midnight saliva cortisol. Midnight saliva cortisol will be more. And the investigation of choice is going to be the low dose dexamethasone suppression test. This is the Cushing syndrome. Then comes the adrenal insufficiency. If the adrenal gland is damaged, it's called as adrenal insufficiency, also called as Addison disease. In that, the entire adrenal gland is not working. If the entire adrenal gland will not work, there's going to be decrease in aldosterone, there's going to be decrease in cortisol, and there's going to be decrease in the sex hormone. All the three hormones will decrease. Because the aldosterone will decrease, there's going to be decrease in the sodium, there's going to be decrease in the blood pressure. Cortisol is less, so there's going to be decrease in the blood glucose. So the patient can go into hypo. The sex hormone is less, so there's going to be decrease in the libido. So if you see a condition where the aldosterone is less, they are talking about adrenal insufficiency called as Addison disease. Can you tell me what is the investigation of choice for Addison disease? What is the investigation of choice? Yes, it is going to be the co-centropin stimulation test. We'll do the co-centropin stimulation test. The next we are discussing is acromegaly. I will tell you the 5 questions from acromegaly and the recent trend. If you see from the NEET PG and your exam, they are asking the out of these 5 questions, they are regularly asking the question. In acromegaly, basically there is increase in the growth hormone. The screening test of choice is IGF-1 levels. If there is more growth hormone, the IGF-1 will be more. The confirmatory test is what we do is we call the patient in the morning, we check his growth hormone level. That is going to be high. Then we are going to give him oral glucose, and after that we again check the growth hormone. If you and me, if we eat glucose, the growth hormone decreases. But in the patient of acromegaly, the growth hormone is still high. This is called as the glucose challenge test. So the first question is the screening test of choice. The second is the confirmatory test. The most common cause of death is going to be cardiovascular. But if they ask that, what is the most common cancer in these patients, is going to be colon cancer. Because in this patient, the polyps which are there in the intestine, they will become big. The most common cancer is colon cancer. And lastly, what is the mechanism of pegvisomant? It is growth hormone receptor antagonist. These are the 5 questions that you must remember. Again, repeating the 5 questions. The investigation of choice is going to be oral glucose challenge test. This, I am thinking that this may come this time. The investigation of choice for acromegaly, oral glucose challenge test. We give the glucose. Before that, we check growth hormone. After glucose, how much is the growth hormone? Then the screening test is IGF-1, the most common cancer, colon cancer, and the growth hormone receptor antagonist is the pegvisomant. When it comes to VIPoma, what is VIPoma is? From the pancreas, we have one hormone coming out called as VIP. What this VIP is doing is, it takes the water molecule and give it to the intestine. If there is more VIP, more water will go from the intestine, blood to the intestine. And all this water will come in the stool, that is watery diarrhea. So if a patient is coming to you for the watery diarrhea for the last 6 months, think of VIPoma. Because so much of diarrhea will happen. And I told you that diarrhea, can you tell me diarrhea will lead to nagma or hagma? Diarrhea leads to nagma or hagma. Do you remember what is the color of the dress of nagma? What is the color of the dress of nagma? Red. And what was D? D is for diarrhea. So diarrhea will lead to nagma. Nagma means metabolic acidosis, normal anion gap metabolic acidosis. So if a patient is presenting to you with watery diarrhea, with metabolic acidosis, hypokalemia, you should think of VIPoma, also called as Vada syndrome. What is Vada syndrome? Watery diarrhea, hypokalemia, and acidosis. Watery diarrhea, hypokalemia, acidosis. It's Vada syndrome, also called as pancreatic cholera. When it comes to glucagonoma, it's a condition where there is more glucagon. And if there's more glucagon, more glucose, there is a chance of diabetes. And what is the skin finding of glucagonoma? Necrolytic erythema migrans. Your exam question, the glucagonoma, the skin finding, necrolytic erythema migrans. Then there is a small table which we need to remember. There is nothing much to explain. The table of men. What are the components of MEN1, MEN2, MEN3, MEN4, right? The MEN1 and MEN4 are very similar. Pituitary tumor, parathyroid tumor. Pituitary tumor, parathyroid tumor. The third one is changing. In the MEN2 and MEN3, the first two are same. Medullary pheochromocytoma. Medullary pheochromocytoma. The next one is changing. So you have to remember all the component of Wermer syndrome, MEN1 except or MEN2 except, right? We need to remember that. Now, the last thing, the second last thing, sorry, pulmonology. Someone is asking how much time it will take more, maybe just half an hour and we'll be done. Half an hour more. So when it comes to pulmonology, the first thing is spirometry. If you see the spirometry report, the first thing you will check is the ratio. They will give you the value of FEV1, they will give you the value of FEC. The ratio is more than 70. There are two possibilities, healthy or restrictive. Then you will check the FEC, because in restrictive lung disease such as fibrosis, the forced vital capacity becomes less. So if the ratio is more than 70 and FEC is normal, it's healthy. If it is less, it's restrictive. But if the ratio is coming less, means the FEV1 is very less, the ratio is coming less, then either it is COPD or asthma. Then you will give the salbutamol and you will do the test again of spirometry, and you will see that how much difference is coming in the FEV1. If there is a significant difference, by giving the bronchodilator before and after, you will check how much is the difference in the pre-FEV1 and post-FEV1. If there is a significant difference, more than 200 ml, more than 12%, this 12% word is important, then it is bronchial asthma. Because bronchial asthma is reversible with bronchodilator. If there is less difference, it is COPD. So this is how we have to approach the question of the, the spirometry. Very important. Ratio, more than 70, restrictive or healthy. Less than that, it's obstructive. And then based on that, we have to figure out that whether it is COPD or asthma. Now let's come to the bronchial asthma part. Bronchial asthma, whenever the allergen goes inside, the most common allergen that is there is dust. When the dust particle goes inside, the first cell that is going to capture the dust particle is antigen presenting cell. Will take this dust to the T helper 2 cells. The T helper 2 cells will activate the interleukin 4, 5, and 13. And because of that, a lot of mucus, a lot of bronchospasm will happen. If you see the mucus, you will be able to see the creola bodies, crystals, cusp, and spirals will be there. The moment the dust goes inside, the patient will start coughing, shortness of breath, chest tightness, sinuses will happen. When you will auscultate, you are going to listen the wheezing, the musical sound, the whistle-like sound, because whenever there is a spark, the whistle-like sound will be there on the auscultation like this. The wheezing is there. When how to confirm this? We'll check the peak expiratory flow. If the patient is coming asymptomatic and you are thinking that he may be having bronchial asthma take in the past, you will check his peak expiratory flow, the best value. And then you will tell him that whenever the next time you feel chest tightness, you blow the air again. And if there is a significant decline in the peak expiratory flow, more than 20% decline is there, it is bronchial asthma. If the patient is symptomatic, we can go for spirometry. Now, the acute attack is of three types: moderate, severe, and life-threatening, depending how much is the decline in the peak expiratory flow. If the decline from the best, if they, for example, if someone is having the peak expiratory flow of 500, if there is a decline of 50%, it's moderate. If it's more than that, it is severe. If the decline is very significant, it's coming less than 33% of the best effort, life-threatening. This is the important question. How to manage acute attack of bronchial asthma? First, we will nebulize the patient. First thing first, how you'll identify its asthma? If a patient is coming to you and he's saying, sir, I am having breathing difficulty, I am having cough, when you will auscultate, you are able to listen the wheezing. It is bronchial asthma. Then first thing you will do the nebulization with the bronchodilators, formoterol, ipratropium. If it works, very good. If not, then you will give hydrocortisone. If it doesn't work, then you will give magnesium sulfate. If it doesn't work, then you will have to put the patient on ventilator. But when you are doing this, during this entire thing, if the patient becomes drowsy, if the patient is becoming unconscious, immediately put the patient on ventilator, immediately. Once you did this, and now there are two questions which has came this time in the NEET PG exam. Listen to this thing and give me this answer. And I want everyone in this classroom to remember these two statements. See here. If a bronchial asthma patient is there, for prophylaxis, which drug we are going to give? Steroids, right? For any allergic disorder, the prophylaxis is steroid, the inhaled corticosteroid. The question will be like this. There is a patient of bronchial asthma. He was given the steroid for the prophylaxis. But despite taking the inhaled corticosteroid, he's developing the asthma attack. What is the next drug you want to add to him? If the steroids are just not working, what is the next drug we are going to add? LABA, long-acting beta agonist. This is the answer. What is the next thing to be done? Add LABA in the treatment. Second question. If it doesn't work, then we give the monoclonal antibodies. What are the monoclonal antibodies? I am just writing one name, bernalizumab. Bernalizumab, they will ask what is the mechanism of action. The mechanism of action is it is going to work against interleukin 5R. When this question will come, the R word will not be written. The answer will be interleukin 5. Bernalizumab, the mechanism of action is it is against the interleukin 5. Must remember these two questions. Repeating again. Asthma patient is there, he's taking steroid, but it's not controlled. What is the next drug you will add? You will add LABA. This is the question. Second, bernalizumab, what is the mechanism of action? Interleukin 5, interleukin 5. You will get confused in the exam because the options are interleukin 4 and 5. Both are written there. The answer is interleukin 5, 5, bernalizumab. The next is sarcoidosis. Sarcoidosis is a disease where you have a lot of granulomas. And which cell makes the granuloma? It is the T helper 1 cells. The granulomas can be anywhere in the body from head to toe. These are the non-caseating granulomas, and these granulomas are because if a person is having HLA-B8, the T helper 1 cells will get activated. Because of that, there is going to be increase in the interferon gamma. If there is more gamma, there is more granuloma. G for gamma, G for granuloma. And these granuloma have two futures. Sometimes these granulomas can disappear on its own. Sometimes they will undergo non-caseous necrosis. Most commonly, these granulomas are found in the lungs and they will make a triad, particularly the right hilar lymph node, the right paratracheal, right hilar, left hilar. This triad is called as Garland's triad. These granulomas can be there in the skin, that is erythema nodosum. They can be there in the face area. They can be in the eyes, that is mutton fat creatic precipitates, anywhere. They can be in the joints. If a sarcoidosis patient is presenting with erythema nodosum, ankle arthritis, hilar lymphadenopathy, it's Lofgren syndrome. The investigation of choice without biopsy, you can never ever make the diagnosis. And when you do the biopsy, you should be able to see the non-caseous necrosis. The drug of choice is steroid. If they ask a question that, what is the stage of sarcoidosis? They will say like this, look at this staging system. The first place where the granuloma actually is made, the first place the granulomas are in the lymph nodes. If a person is having hilar lymphadenopathy, it is stage 1. Along with the hilar lymphadenopathy, if the granulomas are there in the upper lobe of the lungs, it is stage 2. But in the stage 3, the hilar lymph nodes, they will disappear. And only the granulomas will be there in the upper lobe of the lung. If there is only pulmonary infiltrate is there, it is stage 3 sarcoidosis. So they use the word only pulmonary infiltrate is which stage of sarcoidosis? Stage 3. Many of the times we think that only involvement of the lungs. So we might think stage 1, stage 2. No, only pulmonary infiltrated is stage 3. Stage 3. Now coming to the pneumonia. In the pneumonia, they love to ask about the etiology. They give you the hint and they ask you the etiology. For example, because the pneumonia diagnosis is very simple. The patient will have fever, will have cough, and will have shortness of breath. Fever, cough, shortness of breath will be there. So symptomatically, there is no problem. Symptomatically, you can easily find out. If a patient is coming with fever and cough, fever is infection, cough means there is lungs involvement. Fever and cough, you will think of pneumonia for sure. You will think of pneumonia. But they ask, what is the etiology? If they say that the patient is having a lot of poor dental hygiene, dental caries are there, the infection is Streptococcus mutans or anaerobic infection. If the patient is having the parrot or pigeon in the house and the pneumonia happened, it is Chlamydia pistachii. If there is exposure to the bat, histoplasma, exposure to sheep, goat, cattles, Coxiella bruneti, central AC exposure, Legionella. If the patient is having cystic fibrosis or some other structural lung disease, Pseudomonas. If the patient is having HIV, the most common overall infection is TB. If the viral infection of pneumonia, cytomegalovirus. Fungal pneumosis is EOSI. Rabbit exposure, Francisella tularensis, alcohol, Klebsiella. And Klebsiella is going to involve which lobe? Upper lobe. You can remember like this. When you go to club, you drink alcohol and you become high. You go to upper level. You become high. And can you tell me that what is the X-ray finding? In the Klebsiella, we have the bulging fissure sign. Klebsiella pneumonia will have the bulging fissure sign. Can you tell me what is round pneumonia? Streptococcus pneumoniae is the round pneumonia. What is walking pneumonia? Mycoplasma. Mycoplasma is the walking pneumonia. Then comes the ARDS, acute respiratory distress syndrome, also called as blast lung, white lung, wet lung. First thing first, in the ARDS, the oxygen is less, but the carbon dioxide is normal. The carbon dioxide is not increasing. The acute respiratory distress syndrome can happen because of pneumonia, can happen because of toxic gas, the near drowning, even multiple blood transfusion. Can you tell me this answer? Multiple blood transfusion you have did, and after that the ARDS is happening. This is called as what? Multiple blood transfusion leading to ARDS. This is called as TRALI, transfusion related acute lung injury. Transfusion related acute lung injury. The multiple blood transfusion leading to ARDS, it is TRALI. How to treat this patient? In ARDS, we can't do anything much. The recovery will happen automatically. We will give steroid to decrease the inflammation, but mainly we have to put the patient on ventilator. And what they will ask? The setting of ventilator. Remember, they will ask the setting of ventilator for ARDS. You are going to keep the pressure high, high PEEP, low volume. Remember this. High PEEP, low volume. From ARDS, I want you to remember two questions. ARDS, what is the ventilator setting? High PEEP, low volume. And after multiple blood transfusion, if the ARDS happens, that is going to be the TRALI. That is going to be done. There are the diagnostic criteria is Berlin criteria, and what is not a component of Berlin criteria? PCWB is not a component of Berlin criteria. In the Berlin criteria, we take a ratio PaO2 FiO2 ratio. If the ratio is less than 300, it is mild ARDS. If the ratio is less than 200, it is moderate ARDS. And if the ratio is less than 100, it is severe ARDS. This is how we see the ARDS. If there is a long bone fracture was there, and after that, after 3-4 days of long bone fracture, you know that in the femur we have a lot of fat. The fat can come in the lungs, can block the pulmonary artery. That is the fat embolism. In that, there is going to be decrease in the platelets. What is decompression sickness? Those who are deep sea divers, when they come up, if they come up very early, the decompression happens, and because of that, in the blood we have the nitrogen, which is soluble. But the moment you come out of the sea, the nitrogen bubbles are created in the blood, and these bubbles can go in the pulmonary artery and can block the pulmonary artery. This is called as the decompression sickness. During the rapid ascent, if the deep sea diver is coming very fast on the surface, the gas bubbles are formed and they can lead to embolism. Is called as Cation disease. Cation disease. If they say there is a DVT, if the DVT is there and now the patient is presenting with the breathing difficulty, DVT and breathing difficulty, it is going towards pulmonary embolism. In the pulmonary embolism, there is going to be damage to the right ventricle. Can you tell me that? This is called as what? On the echocardiography, you can see that the right ventricle is not working nicely. Can you tell me this is called as which sign? This is called as Hampton-Hum, Palla sign, Westermarck sign, or McConnell sign. The damage to the right ventricle in pulmonary embolism, this is called as the McConnell sign. The next is the pulmonary artery hypertension. If the pulmonary artery pressure is more than 20, it's called as pulmonary artery hypertension. It is associated with the BMPR2 mutation. But the most important is if you see a young female presenting with the progressive shortness of breath with loud S2, the moment you see this word, it is pulmonary artery hypertension. It's very important. What happens is pulmonary artery hypertension is there is a constriction in the pulmonary artery. It happens in the young female, and because of that, less blood will go to the lungs, so the patient will have shortness of breath. In young female, progressive shortness of breath, loud S2. The moment you see this trio, pulmonary artery hypertension. And what is the treatment? We are going to give bosentan that is going to block the endothelin A and B receptors. So there is going to be vasodilation will be happening. The summary of obstructive sleep apnea and obesity hypoventilation syndrome. Now look at here. Whether it is obstructive sleep apnea or obesity hypoventilation syndrome, in both of them, the patient has obesity. In both of them, the patient does not feel very energetic. The patient will feel not concentrated, not in good mood. In both of them, the same things are there. But in obstructive sleep apnea, the problem is only happening in the sleep time, which you can detect. But in obesity hypoventilation, the hypoventilation is happening in the daytime as well as nighttime both. So in obstructive sleep apnea, if you see the daytime carbon dioxide, normal. Whereas in obesity hypoventilation, the daytime carbon dioxide is also more. So they love to ask you that whether you are able to know the difference between the sleep apnea and hypoventilation syndrome. In both of them, the patient will be obese. In both of them, the patient is lethargic, not feeling concentrated. How to differentiate daytime carbon dioxide? If the daytime problem is there, it is hypoventilation. If only nighttime problem is there, the daytime carbon dioxide is coming normal, it is a sleep apnea. How to differentiate between the exudative and transudative pleural effusion? Whenever a pleural effusion is there, we are going to take the pleural fluid sample and we will take the blood sample also. We will send both the samples to the lab, and in the lab we will ask that check how much protein is there and how much LDH is there in the pleural fluid and in the blood sample both. And then the report will come and we'll compare that to find out whether the pleural fluid is exudative or not. This is called as light criteria. How will compare? Whatever the pleural fluid report has came, let it be there. But the plasma means the blood. In the blood, whatever the report they have given, for example, whatever the blood protein, the lab has said that in the blood of this patient, the protein is, let's say, 200. You will multiply with zero point 0.5, then you will compare. Whatever is the LDH of the blood, you will multiply with zero point 0.6, then you will compare. And if anything is coming more, the pleural protein is more than zero point 0.5 protein of the blood, or the pleural LDH is more than 0.6 LDH of the blood, then you can say it is exudative pleural effusion, and this is light criteria. This is light criteria. There was one question in your exam. Let's see whether you are able to answer that. Can you tell me Beer criteria? What is Beer criteria for? Beer criteria. Beer criteria is used for what? Beer criteria is in the old age, there are some patient who takes multiple tablets. You have seen in old age they are taking tablets of hypertension, diabetes, stroke, CAD, many drugs. So multiple drug interaction can happen. To find out the multiple drug interaction, we use Beer criteria. So in the old age, the multiple drug interaction is happening or not. Multiple drug interaction. To find out that, we will do the Beer criteria. We will use the Beer criteria. The next is the pneumothorax, a medical emergency. So they love to ask the medical emergency. What happens in pneumothorax? If you remember the name of the patient, can you tell me the name of the patient if you're there in the class? There was a long, tall one of your friend. What is the name of that? Bulla Singh. There was a patient, Bulla Singh. He was having a lot of bullas in his lungs. And one day, one of the bulla ruptured. The moment the bulla will rupture, a lot of air will come in the pleural space, and that is going to compress the lung. It's just not going to compress the lung, plus it is going to put the pressure on the trachea and the heart. So that is going to go towards the opposite side. The lung is completely collapsed. The patient will have acute shortness of breath. If a person is having acute shortness of breath, when you are going to do the percussion, because there is only air is here, so when you do the percussion, the sound will be like a drum, dum, dum, dum. So if there is hyper-resonant sound is coming on percussion, it is going towards pneumothorax. What is the immediate management you are going to do for pneumothorax? Whenever they use the word immediate, the immediate management is going to be the large bore needle insertion, followed by chest tube. This was your exam question this time. They have used the word immediate. Immediate means large bore needle. You have to insert the needle, release the air immediately. This is the X-ray of pneumothorax. Because in the pneumothorax, the lung has been collapsed. Here you can see the collapsed lung. Rest is the complete air. So there is increase in the blackness. There is increase in the blackness. Is there? The next is bronchiectasis. Bronchiectasis means abnormal airways, abnormal shape of airways. Abnormal shape of airway is called as bronchiectasis. Now, because of the abnormal shape, there will be a lot of mucus in the pouches of the airways. And when the patient is going to cough, the bad smell mucus will come. So if you see these words, high volume, foul smelling sputum, high volume, foul smelling sputum, very bad smell sputum is coming, very high volume, on and off fever is coming, it is bronchiectasis. In the bronchiectasis, we are going to see the clubbing. One of the early sign of clubbing is the loss of Shamroth window. Normally, when you put the nails like this, from index finger nail to nail like this, there is a small window is there like this. But if the small window is not there, it is Shamroth sign. It is the early sign of clubbing. Clubbing is not seen in which condition? Clubbing is not seen in COPD. Not seen in COPD. So bronchiectasis, what are the two questions they are love to ask in bronchiectasis? One, how to make the clinical diagnosis. High volume foul smelling sputum, it is bronchiectasis. The second question is the radiological diagnostic criteria. When it comes to the radiology, the investigation of choice, it is HRCT. Can you tell me what are the findings on HRCT? There is going to be signet ring appearance, tram-track appearance, signet ring appearance, tram-track appearance will be there on HRCT. The treatment is simple. We have to treat the cause. We have to remove the mucus. We have to give the antibiotic. They don't ask the treatment. They ask the diagnosis. High volume, foul smelling sputum, it is bronchiectasis. Then coming the interstitial lung disease, ILD. ILD means the fibrosis in the lungs. Whenever there is a patient is presenting to us and he is having fibrosis in the lungs, we want to find out why. So first we'll ask that, does you work in any bad environment where there is a lot of bad dust is there, such as organic dust, inorganic dust, radiation? If the patient says, no, I am not working in any such environment, then we ask that, do you have any disease which can lead to fibrosis, such as scleroderma, rheumatoid arthritis, SLE? He said, no. Then we'll do the lung biopsy and we'll try to find out that why he is having fibrosis. If in the biopsy, we are able to see the UIP pattern, which is actually the most common type of fibrosis finding, then this is called as idiopathic pulmonary fibrosis. But I will tell you 5 questions from this flow chart, which is super important, which I have already told you in the class also. If they say a patient is presenting with fibrosis and he is a smoker, the moment you see the word smoker, you have to see where is the fibrosis, upper lobe, lower lobe. If it is in the down lobe, lower lobe, the answer is D, squamative fibrosis. If it is in the upper lobe, it is RBILD. This is the first question. Second, if they say the patient is having Sjogren syndrome and he is having fibrosis, the answer is NSIP, good prognosis. If the patient is having honeycomb appearance in the CT scan, it is UIP. And the worst prognosis is the acute fibrosis, AIP. So these are the 5 questions to be remembered. Again, repeating the 5 questions. First, if there's a smoker is having fibrosis, then this is the most important question actually. Smoker having fibrosis, either upper lobe, RB, lower lobe, desquamative. If the Sjogren syndrome is mentioned, then it is NSIP. If honeycomb pattern on the CT scan is seen, then it is UIP. And which has the worst prognosis, AIP. AIP. Now coming to the last thing in the medicine, it is nephrology. The first topic we are discussing is the renal tubular acidosis, RTM. Type 1 RTA, there's a, see what is RTA is, let's understand the basic concept. The function of the kidney is to throw out the acid and to save the alkaline things. We want alkaline molecules. We don't want acidic molecules. If the kidneys are not working, the acid will not go out, the acid will increase. That is acidosis. Or if the kidneys are not working, we are not able to pull the bicarbonates, we are not able to pull the alkaline things. And if the alkaline thing will not come, that is again acidosis. So if the distal part of nephron is not working, the alpha integrate cells are not working, which is able to throw the acid out. If the alpha integrated is not working, you will not be able to throw the acid out. The acid will increase. It's called as type 1 RTA. If the proximal convoluted tubules are not working and you are not able to pull the alkaline molecules inward your body, if the proximal convoluted tubules are not working, the bicarbonate is not pulled and acidosis happens, it is type 2. If 1 and 2 both are happening, it is type 3. If the RAS system is not working, what is the RAS system is doing? RAS system is absorbing the sodium and throwing out the potassium and acid. If the RAS is not working, the potassium and acid will increase. That is type 4 RTA. If you can't remember all the RTAs, the must remember 2 words. If they use the word Sjogren syndrome, the patient is having Sjogren syndrome and he is having RTA, it is type 1 RTA. The only RTA which is having hyperkalemia, it is the type 4 RTA. If you can't remember even 2 statements, remember 1 statement, which RTA is having hyperkalemia, type 4 RTA. Type 4 RTA is having hyperkalemia. One more point. Can you tell me that, okay, RTA is done. Can you tell me that in tumor lysis syndrome, what happens with calcium? RTA is done. In tumor lysis syndrome, what happens with serum calcium? The serum calcium is going to decrease. Everything increases in tumor lysis, potassium, uric acid, everything increases, but the calcium is going to decrease. Then comes the syndromes. The Bartter syndrome, Gitelman, Liddell, Fanconi. The Bartter syndrome and Gitelman syndrome, they are very similar. In both of them, we are losing 6 molecules. But the difference is in Bartter, we lose calcium, and here we lose magnesium. That is one major difference. Liddell syndrome, the ENaC is working more, it's called as Liddell syndrome. If the ENaC work more, you absorb more and more sodium and you throw out more and more K plus and H plus. So more sodium will increase the blood pressure, and this is called as the low renin hypertension. If you see this word low renin hypertension, Liddell syndrome. Fanconi is very simple. The entire PCT is not working, is the Fanconi, and if the PCT is not working, we will lose a lot of molecules out from the body. It is called as Fanconi. If we are losing the chloride in calcium, it is called as DENT. So if you are losing magnesium, it is Gitelman. Losing calcium, it is Bartter. If the ENaC is working more, it's Liddell syndrome. Among them, the most important is Liddell and Bartter syndrome. In Bartter syndrome, we lose the calcium along with the 6 molecules, and Liddell is the low renin hypertension. The last is the nephrotic and nephritic syndrome. Now, here I will give you some hints first. Once we'll complete this, then I will tell you about the 30 days plan, that how we should plan for the 30 days. When it comes to the hint, if in the question they have mentioned proteinuria plus minimal hematuria, minimal or no hematuria, no RBCs are coming in the urine, it is nephrotic. But if they have mentioned proteinuria plus significant hematuria, if the hematuria is mentioned, then it is going towards nephritic. So first thing first, this is how we differentiate nephrotic, nephritic clinically. The hematuria is significantly there or not there. If it is not there, nephrotic. If it is there, nephritic. Now, which disease is going to be there? If there is only proteinuria is there and it is a child with Hodgkin lymphoma, the answer is minimal change disease. Because minimal change disease occurs in the Hodgkin lymphoma patient. If the proteinuria is happening and the patient is having HIV, the answer is FSGS. If the patient is having hepatitis C, the answer is FSGS. Hepatitis B, it is membranous nephropathy. If the solid organ malignancy is mentioned, a patient is having lung cancer, stomach cancer, and he is having nephrotic syndrome, the answer is membranous nephropathy. In the nephritic syndrome, if they mention that the person is having some throat infection, some GI infection, and within 2 days the hematuria is happening, it is IgA nephropathy. But within 2 weeks, if the problem is happening, then it is PSGN. After the infection, after the 2 months of the skin infection, if the hematuria is happening, then again it is PSGN. So PSGN can happen after throat infection, after skin infection. The time duration is different. In the RPGN, there is rupture of the basement membrane. The basement membrane is ruptured. And because of that, there is going to be proliferation of parietal epithelium. And what will the shape that you will be able to see in the crescents? If you see the word crescent, it is RPGN. RPGN. Yes, it is very easy. These are the buzzwords to be remembered. If you remember these buzzwords, you will be able to find the answer. But the main thing is going to be biopsy. In the biopsy, if they write spike and dome appearance, then it is membranous nephropathy. Spike and dome. Spike and dome, it's membranous. Right? The crescent is going to be the RPGN. So this is all about from the important part of the nephrology, the nephrotic nephritic syndrome. And this is all about from the medicine part. Thank you for being with me for the last 4 hours continuously, almost just one technical break that we have got. वो भी किसी ने काला जादू कर दिया तो मिल गया अपने को, right? Otherwise तो we would have not having that break also. Anyways, now let's come to this 30-day. Yes, I would not say that this is enough. See, the point is, I would say like this. If you have revised your notes nicely, if you have gone through that, this is a video that is going to help you boost you that what are the main elements that you must remember. But at the same time, there are some of you, I know that many of us feel that medicine is very big subject and at times it's difficult to revise for us. So we kind of skipping the entire medicine. If you are kind of skipping the entire medicine, it is better than you go watch this video multiple times. At least you will feel little confidence in the exam. I will not say you will solve all the questions, but yes, you will be able to eliminate some option. You will be able to solve some question, and you will feel at least some confidence will be there. If you have done the main notes, the workbooks, then yes, definitely do that. And that is just a supplement to be used. You watch it multiple times so that the main elements will be covered. You will not miss on the main elements. This is what was the idea of this almost 4.5 hour, 4 hours, 10 minutes of the session that we had, right? And now coming to these 30 days, right? Let me take the queries one by one from your side and okay, pencil is also discharged, so we can talk for 1 more minute than 1 2 minutes. अभी नीट पीजी कर लेना ना यार, तुम्हारी नीट पीजी होगी तब देख लेना, देखने में क्या बुराई है, नीट पीजी भी यही है, इट्स नथिंग डिफरेंट, राइट? इट्स द सेम थिंग दैट दे आस्किंग, इट्स नॉट द मेम्ब्रेनस नेफ्रोपैथी इज नॉट कमिंग इन नीट पीजी और दिस एग्जाम और दैट एग्जाम, इट इज गोइंग टू बी द सेम. Yes, definitely tomorrow you need to attend that. Yes, yes sir, yes, I'm just waiting this pencil थोड़ा सा discharge हो गया ना, बूढ़ी हो गई है पेंसिल भी, so gets discharged. Just waiting for a minute. Meanwhile, you can write your things in the chat box so that I can read it and I will accordingly will give the answer. मोटिवेशन इज राइटिंग कि फिंगर से लिख दो. इतना मोटिवेशन नहीं है मेरे में, फिंगर से लिख दो. उसका नाम भी मोटिवेशन है. मेडिक मोटिवेशन बोल रहा है फिंगर से लिख दो. तुम्हारा जितना मोटिवेशन नहीं है भाई मेरे पास. I would have shown you the weather outside. It's extreme. -23 is there in the weather. Extreme weather, but it's already dark. Otherwise, I would have shown you the complete white layer all over the trees everywhere. Okay, let's come to the first point. GT, MCQ, notes. First thing first. When it comes to GT, I don't want you to give the GT anything after 5th of January, rather 3rd of January. I want that last should be before 3rd of January. And don't worry about the marks. कितने भी आ रहे हैं, 100 marks, 120 marks, 180 marks, 270 marks, no problem. Whatever it is, neither we have to be very much encouraged by these marks, neither nor we have to be demotivated. We just have to find out that कि मैं आसान क्वेश्चन सही कर रहा हूँ कि नहीं कर रहा हूँ. Because I can give you a GT right now where you can score 250. On the next day, I can give you one more GT where you can't score 100 also, right? So it depends on the level of paper also. So the score doesn't much make a difference. It makes the difference that key whether we are able to do the time management or not. Secondly, whether the notes which I have read, if the question is coming from those notes, whether I am making right or wrong, that is what we need to assess. Every day, minimum 50 to 70 MCQs should be done. Minimum. If you can do more, very good. Now coming to the notes, and I feel that this is the very vital part. Now, your brain will definitely will say that to go for some shortcuts. Don't go for shortcuts. Yes, if you are very weak in particular subject, then you can go for shortcut for that subject, but rest, no. If you are weak in any two subjects, find out that which are your two weakest subject. Any two weakest subject, make a rule that every day you will read 30 minutes SNAP. Every day till 16th of January. For example, let's say for me, anatomy and microbio is weak. So what I will do is I will read every day 30-minute micro, 30-minute anatomy. Every day. Whatever is going to happen, that will be covered by this. I will not read more than that. This is what I will do for my weak subject. Now I left with 17 subjects. So 2 subjects are done. Out of 17 subjects, I want that mainly to divide into two categories, 12 plus 5. 12 subject I want to be good. Good means very good. If the question will come from the workbook, it will not go wrong. And what I will do for that, I will read the workbook multiple times very quickly. I will not stop in thinking कि मेरे को याद हो रहा है कि नहीं हो रहा है. If I will stop, it consumes a lot of time and my brain will give then alternate ideas to do the things. So I will not stop. I will flip the page, I will flip the page, I will read, I will understand, I will go. Then I will come back again. Then I will complete, I will come back again. This is what I will do for 12 workbooks cover to cover without skipping any single topic. These 5, I will do the workbooks, but in between, I can skip some topics. For example, in cardiology, I can, if cardio is coming in my 5 subjects, in cardiology, if I'm not good with the ECG, then I will just read 5 lines. Irregular, irregular, it is atrial fibrillation, COPD, MAT, it is MAT, PSVT, this, that, just 5 lines, I am done. So I can skip some part in these 5 subjects. But again, the speed of reading is going to be fast. So for this is how I will plan the theory for me. Now, when I'm planning the theory for me, whatever you are doing perfectly fine. But from 8th of January, 8, 9, 10, 11, 12, 13, 14, 15. I will keep these 3 days and these last 6 days, or let's add one more for your convenience, 7 days. In the last 7 days, whatever revision I have completed till 6th, I will stop all my workbooks at that particular moment. On 6th, I will close my all the workbooks and now I will arrange them in the sequence. I will put first 12 workbooks, which I am very good, then the 5 where I'm okay. And I will start flipping the pages. The target is very simple. In the 7 days, all the 17 subjects workbook, I have to go from cover to cover. I have to go very quickly, not thinking. It is only possible if you stop thinking कि मेरे को याद हो रहा है कि नहीं हो रहा है, then only it is possible. Once I will be completed that, now coming to these last 3 days, there are two things that can be done in these 3 days. One, you can go subject specific or category specific. Subject specific, if you are going, try to do PSM, gynae, pharma, micro, biochem, or maybe some other, if possible for you. But at least this many. This is subject specific. If you don't want to go subject specific, you want to go for category specific, then go for this category. Read these things again here. But I would say that go for subject specific. PSM, gynae, pharma, micro, biochem, or maybe even patho you can add. Go for subject specific, cover it, and we will be sorted. Now, that is why I'm saying that don't give a lot of GDs. Some of you are giving GD every third day, every fourth day. What we are getting out of that? It's not that the questions are going to be repeated a lot. 300 में से 30-40 क्वेश्चन रिपीटेड आएंगे, बाकी तो नए आएंगे ना यार. The language will be new, the concept based question will be there. So the new question is going to change the game for us, because the majority of part is going to be the new conceptual questions, and for that we should know the theory, we should know the concept. I am not saying that the question practice is bad. Practicing question is good, but only practicing question is not going to be helping us. We have to do some other things also, right? So I think that we have taken care of your GT part, the MCQ part, and the notes part also. If anything is there, you can write in the chat box. Otherwise, yes, राजा तो आप हो, हम तो प्रजा है, मजदूर हैं, हम तो प्रजा भी नहीं है. लिखते रहो, लिखते रहो, लिखते रहो. Yes, I will be sending the PDF to you. Don't worry about the PDF part. It will be coming to you immediately. But make sure that these next 30 days, if you will not have that thought कि मैं कितना पढ़ पाऊंगा, कितना नहीं पढ़ पाऊंगी, if you remove that thought and you start flipping the page, definitely will clear this exam. But बार बार यही सोचते रहेंगे कि मेरा कब खत्म होगा, whether I will be able to complete or not, then कभी खत्म नहीं होगा. Then we are going to lose a lot of things on that, in that thought process itself. So let's come out of that, right? And it is not difficult, guys. It is not difficult. It is just a matter of time that these 30 days, how we perceive them, how good we utilize them. If we utilize them nicely, definitely, yes, you are going to clear the exam. It's as today itself you are knowing that much. ये खाली मैं बोलने के लिए नहीं बोल रहा हूँ. Today itself, if you are prepared decently for the last 5 months, you know that much कि you can clear the exam. It is that whether you are able to retain and recall the things under pressure of exam, whether you are able to recall the things in the examination hall or not. That is the main thing, right? And for that, we have to create that reflux by flipping the pages multiple times so that the synapse will be more strong, and under pressure also, these synapses are going to fire for you. So wish you a lot of luck, best wishes, and this ऊपर वाले ने देखा है, आपने खूब मेहनत की है, the sleepless nights, right, and so much of pressure you have felt. Definitely, yes, we all are with you, and 100% you are going to make it happen. But make sure that these 30 days you are working is heart out. बाहर आ जाना चाहिए दिल, इतनी मेहनत होनी चाहिए, तो मजा आएगा, right? Thank you. Thank you, guys. Good night.